Okay, no problem.
Yeah, we are live now.
Okay. So it's live?
Yeah.
Okay. So shall I start?
5 more minutes. Let a few more people join.
Okay. So let me check the YouTube. Whether it's going on or not. Oh, it seems going.
Yeah.
So I think we should share this on our. It's going on now. Yeah. So let me share in our social media group, also Facebook. Just let me know when to start, okay?
Yeah, we'll start by 9:05. 9:05 we'll start. No problem.
Okay.
In another 2 minutes we'll start. Then it'll be 5 minutes. We have waited for everybody to join water. Yeah, we have got few viewers in YouTube.
Any idea why my face is coming distorted? Can you help me, sir?
Sir, I think it's because of that background, this thing, sir. If you move a little bit, one space back, sir, with your chair, if you can move one space back, your full face will come. A little bit, sir, left, sir. Move towards the left a little bit. I think it's the camera, this thing. Whole thing is. Sir, you can use the DY Patel, sir, this thing itself, sir. Video setting. So I think a little bit to the left, I think we are getting.
Yeah, let me just check with the other backups.
Yes. So we'll start. Good morning, everyone. It's a great honor to start our ISSEM Sports Medicine webinar. We are in live in YouTube, as well as those who are members can directly enter into our WebEx meeting. First, we will start with Dr. Barun, who is our president. There is not there's a lot to say about Dr. Barun. He started his PG dip in sports medicine from Patiala, and then he did his MD physiology from AIMS. He was in AIMS for quite some time. After that, he has been spreading his wings all over the place, and right now he is with BHU. I don't need to give a bigger explanation about Dr. Barun because everybody knows him, and there is nothing to speak adulations about him, because he has done a lot for our ISSEM, and he shall start the proceeding as our president, and I give the stage to him.
Thank you very much, Dr. C. So it's very nice, to start ISSEM webinar series for 2024, and I thank you very much, our General Secretary, National General Secretary, for taking this. So. I welcome all the members who have joined through our WebEx, and all those listening to our live YouTube. You can put your query in the appropriately if time permit. And let me begin by talking a little bit about the sports medicine, because I mean, many things has been talk about sports medicine, but still there are some misconceptions are always there. So let me begin my talk with little bit about the sports medicine. Sports medicine, can be taken historically, can be taken as a broad specialty or as a medical specialty. In India, we have medical specialty, recognized medical specialty. Specialty of the sports medicine is basically sports and exercise medicine, where knowledge, competency, expertise are required from two broad field of science. One is related with performance, that is sports, exercise, and human performance. Another is the medical aspect, medical, clinical, and the allied health aspect. Broad domain of science is very much essential for sports and exercise medicine, where we the sports medicine doctors not only deal with the complex or illness or medical problems, or a team caring of the team, that is a team physician concept, medical care of the team, and even all the event related with the team, like for example pre-participation, medical the examination, emergency sports and exercise medicine, traumatology, team travel, jet lag and all that stuff. Sports medicine also deals with the performance enhancement, with the training, nutrition, psychology, or any type of the scientific intervention, or sports pharmacology, anti-doping, and all the substance abuse and all the ethical concept. It's also deal with the physical activity and medical care for exercise and physical activity in different situation of the altered the physiological domain, like for example say high altitude, depth, or environment, or deal with a special population. It may be pediatric, female, aging, or disabled, or para athlete, or the athlete who are in extreme or sport. Also the promotion, fitness promotion, say therapeutic use of exercise as a exercise medicine for different chronic non-communicable diseases. So sports medicine is a broad branch. So in this webinar, we are dealing with a small subsection of the sports and exercise medicine, and I will just introduce with all the prominent speaker, and all the speaker we have chosen very carefully, so that they are speaking. Like for example, we are having this overhead athlete evaluation and management by Dr. Praveen. And it's a very important day-to-day common injury or illness which we encountered as a sports medicine physician, painful shoulder, whether it may be because of say rotator cuff tendinopathy or rotator cuff tear, or it may be say deficit, maybe there, or it may be say because of what you call SLAP, that is superior anterior to posterior lesion, maybe there. So there are lots of problems regarding the painful shoulder, and proper evaluation and management is very important. And next, we will be having the session on hamstring, pulling a hammy, clearance to play, how to decide, practical approach by Dr. Chetan. Hamstring is very important, where eccentric load is given to the hamstring, and if not properly strengthened eccentrically, then injury can happen. It may be tear, it may be tendinopathy, depending upon, and how to clear the athlete for return to play. It's also very important how much Nordic hamstring exercise has to be prescribed, how to approach. This is also important. Another practical point which we are going is a pre-travel preparation and approach to the obstacle which one faces as a team doctor. team doctor is a very challenging task, having with a, team. You are the sole guardian of that particular team. You have to take care from everything from a medical aspect to psychological aspect, being just like a parent. Overall care has to be provided by sports medicine doctor. So pre-travel preparation, how much what should be there in your medical bag, what are the lists of the things which you have to prepare, how to tackle long travel, how to schedule if a particular tournament competition is there, how to approach it, how to minimize the jet lag and all that stuff will be taken care by Dr. Deepak Babu. Then we will be focusing on sports science. Sports science is very important. Talent and hard work has a limitation. Sports science has to come if you want to increase, your physiological limit. Without going into the doping and without, going into injury and illness. That is minimization of exercise medicine. So recovery technique will be taken in sports will be taken by Colonel Dr. Anup Krishnan. He is a very senior sports medicine physician, and all the current recovery technique, what actually the science says, because it is very common in highly athletic players. There's certain misconception may be there, which may not be scientific. So what does the science says? What are the different recovery techniques? Whether it may be nutritional technique or any kind of the say manual a technique, or whether it may be any kind of the sports technology related recovery protocol. This will be highlighted by our prominent speaker. Next, we will be talking about weight cutting and consideration for nutritional support in combat sport, where different weight category are there. So how to go about it, and how you can do it. Different, there are so many unhealthy practices which are done by athlete on regular basis. So we have to create awareness. How much, for example, just losing weight because of the dehydration, increasing water loss is not good for your health. How to maintain that optimum body composition, how to maintain the muscle mass by decreasing the fat loss and preserving the water level, that is preventing the dehydration. How to go about it, what are the nutritional support, it will be taken by Dr. Amol. Then we will be talking about overtraining and overreaching. Very important, because see, for optimum physiological adaptation, the training has to be within that particular zone. Because if you do under training, then adaptation will not happen. If you do overtraining, then injury and illness will happen. So but we have to do overreaching, where performance enhancement can be there. Because if you follow the principle of the overloading principle, you have to challenge your physiological system in order to reach that continued adaptation. So overreaching, functional overreaching is important, but you have to avoid overtraining. So there are so many different training principles, so many training so many scientific monitoring tools which are being used in order to stay in that particular optimum zone, so that super we avoid that plateau. So this will be taken by Dr. Ken John Ngomdir. So he is a very senior. Then, after the lunch break, we will have, certain recent advances in the field of the sports and exercise medicine and allied. Like, for example, fibromyalgia is very important. It is one of the hidden syndrome. You may confuse fibromyalgia with chronic, or say overtraining syndrome. It's very common, to confuse fibromyalgia with overtraining, or say painful syndrome, or say a fatigue, continued fatigue in athlete. So how to approach, from sports fibromyalgia, how you have to tackle different what you call trigger point which is happening in different muscle, how to go about it, how exercise can be given as a therapeutic intervention in a patient of the fibromyalgia, and what are the different pharmacological as well as non-pharmacological intervention for fibromyalgia. It will be taken by Dr. Aditya. Then we will be having sports dentistry. Sport dentistry is a highly exciting new field of the dental science. It is basically a missing link in the athletic healthcare. In the sports dentistry, you have to deal with not only what you call sports dental traumatology, but also regarding different say mouth guard. The performance aspect of the mouth guard also it deals with the sports dentistry, and also say what is the effect of say it is very common to use high carb solution foil drinks during sports, and because of that negative effect can be happen on your teeth. So how to approach for that particular teeth optimum teeth health, and how to not only take the emergency dental challenges, how to meet the challenges, but also for performance enhancement, and how to go about sports dentistry education in India. So it will be taken by Dr. Sneha. She is also she is also the director of the sports dentistry wing of our society. Then another one of the most important point is a transgender issue in sports. It is a very complex, very delicate, very highly sensitive. Also, in order to maintain that fairness, that what you call it should not violate the spirit of the sports. Also, where what are the rules we says, because see when you go and see regarding the gender differences in the sports performance, biologically or physiological gender differences there. Just give you an example, like for example, male and on an average, biological male have 40% more muscle mass as compared to the female in the upper body, or say 33% more in the muscle mass in the lower body. And a male will have 25 to 30% or more aerobic capacity as compared to the female. VO2 max is more. And when you have see the lung capacity also, male have nearly around 40% more lung capacity than the females. And if you see, the strength also between comparison between the male and female, you can see that, a pound, 4 pound, the male muscle is slightly stronger as compared to the female, 5 to 10% stronger, or say up to 44% can be stronger. And the bone also, if you see the bone also, male have a longer and larger bone, which provide a mechanical advantage over the female also, and all these features, all these physiological features will definitely create problem if males try to compete in a female sport. Because testosterone, how should be the testosterone level? Like for example, recently it has been said that the testosterone level mole per liter or so. So all these rules and regulation, and what are the challenges which one face, when you deal with a transgender, and how to go about it. Says participation on transgender. So it will be taken by Dr. Khyati. Dr. Khyati is not only sports and exercise medicine doctor, but also an athlete. And lastly, we will have Dr. Kiran speaking about the announcement of our national conference and the election of our society, which will be happening in BHU, IMS BHU, in the November of 2024. So we have lots of important important topics chosen very wisely, and I hope and I request each and every participant to raise their doubt, any kind of a doubt, please raise it, so that question and answer session is also there in between. so that one-to-one interaction happens. Interaction is more important. One-sided lecture, instead of one-sided lecture, which focus more on one-to-one interaction. So stage to Dr. Siddharth to go ahead with the next academic session. And once again, congratulate the entire team for organizing this excellent scientific event. In the future, also this series continues with more specialty belonging to sports and exercise medicine. Thank you very much.
Thank you, Dr. Barun, for the enlightening talk. So, um, um, I think he has already spoken about everything about sports medicine and what our today's sports medicine webinar will entail in detail. Without further ado, I think we are quite on time, so I think we can easily start our webinar. So I'll just introduce our first speaker, who is Dr. Praveen. Dr. Praveen is currently the assistant professor in Savita Medical College, which has got a very good sports medicine, MD sports medicine department. He's also completed his MD sports medicine from VMMC Safdarjung, and he's been working since then in with Dr. Dobson in Savita Medical College. So the topic which we'll be speaking in the next 1.5 hours is called practical aspects of sports medicine. There is one small change in which the third talk, which is about the pre-travel, because the speaker has a small program. So it will be interchanged with Dr. Aditya's fibromyalgia, but the same talk will be happening. Only thing is just interchanged. Otherwise, everything will be going on time. Our first topic will be on overhead evaluation, overhead athlete evaluation and management of a painful shoulder. Since that is one of the most common injury which most professionals, in sports medicine deal with, and one of the most common injuries. And so how do we evaluate it and how do we manage it? This is quite useful for PGs, for physios, for doctors to learn, to relearn a lot of things. And I invite Dr. Praveen to take the stage. Dr. Praveen, if you can video, you can just on your video and share your slides and you can start. Dr. Praveen, can you?
Yes, sir. Is it visible now?
Your slide is on, but your voice is not there yet.
Sir, am I audible now?
Yeah. Now you're audible.
Yes, sir. First of all, thank you for providing this opportunity. I should thank ISSEM for providing this opportunity, especially Dr. Dobson Dominic sir and Dr. Siddharth sir, Dr. Barun sir, and I will like to extend my thanks to that. And I will start my presentation from here on. My topic is on overhead athlete pain evaluation and management. So overhead athlete pain is very common. So in that overhead athlete pain, so the rotator cuff tendinitis is the most common term, but it is also very difficult in terms of both diagnosis and treatment. So the key for any successful management is through the evaluation and correct diagnosis and structured multi-phase rehabilitation protocol you should be keeping in mind. So your evaluation should be correct, the diagnosis should be correct, and the rehabilitation protocol, it should be as per the dependence of the athlete. So the phases of throwing cycle. So we know the phases of throwing cycle are wind up phase, early cocking phase, the late cocking phase, the acceleration, deceleration, and follow through phase. So the wind up and early cocking phase, which accounts for short period of in the entire throwing cycle, the wind up and early cocking phase has very small duration of so it comprises only 20% of the entire duration. So the late cocking phase, the acceleration and deceleration comprises the remaining phase. The acceleration phase comprises of 40 to 50% of the throwing cycle. The remaining 20% will be of deceleration and the follow through phase. So this is the kinetic chain in the throwing arm. So the athlete who is throwing, who is a throwing athlete, is the power is actually is not coming from the shoulder. The power is actually generated from the leg and the hip, followed by the trunk, followed by the shoulder, and is carried to the elbow, and then it's carried to the hand, and then the ball is released or the object which is they are holding in the hand, whether in the form of javelin or thing. The throwing sport, the hand is the ultimate receiver of the power generated which from the legs and hips. This is this you can see from the correlate with the phase of throwing cycle also. So in the wind up and early cocking phase, the athlete is trying to generate power from the leg. So and it's transmitting through the hip and then through the spine and then he carried to the shoulder. And then the power is transduced to the elbow, wrist, and followed by the ball is released. So this is the kinetic chain in throwing concept. So this kinetic chain is very important because we should not evaluate the athlete from the shoulder aspect, whether he is having the pain in form of shoulder. So if the throwing athlete is complaining of any pain and or any reduced performance, you should able to assess the transmitters, that is the power transmitters or the legs and hips and the trunk. So one should also should not forget to evaluate these two aspects. So what will be the history? So the history will be the reduced performance before the actual pain appears in the shoulder. So the player will start complaining of reduced performance. Even before the pain arrives, he will complain of you, especially of a team doctor. Team physio, he will receive that his performance is reduced, especially if a cricketer is throwing from a long on or long off, his speed of throwing and his distance of throwing will be definitely reduced, and that will be the first complaint. And the loss of command, whatever his body demands, it won't be able to perform. So loss of command will be there, and the loss of control of the pitch will be there, and the pitching velocity also will be reduced. And there might be some discomfort, or you can able to notice a subtle change in the throwing mechanics of the athlete. So it should be closely monitored. The pitching mechanics is the same throughout the duration of the season, or whether the pain mechanics is itself able to alter the mechanics of the arm. So these things should be monitored closely. And once the history is done, the physical examination part. In the physical examination part, apart from the routine shoulder test which we are doing, we should not forget to check for the trunk and lower extremity weakness and the dynamic Trendelenburg test. Demonstrate some gluteal weakness or the trunk weakness is there. We able to try to find out, and apart from that, the localized supra or infraspinatus muscle atrophy involvement is there or not, and other this scapular dyskinesia is there or not. So, and any periscapular involvement is there or not. So these are all the physical examination part. One should not forget to look into it, because the earlier also I have emphasized about throwing cycle and the kinetic chain concept. So the kinetic chain part should be evaluated thoroughly in a throwing athlete. For that, the lower extremity and legs and glutes part should be examined, at least be bilaterally comparable. So these things should not be forget. Why I'm strongly emphasizing is that in the clinical practice we tend to miss this trunk and lower limb examination. Is usually tends to get missed either due to the busy schedule, or we should create a checklist in the form of any examination aspect. So if once we created this checklist for these two aspects, these two things won't be get missed. So moving into the individual wind up and early cocking phases. So the wind up phase and the early cocking phase, there is not much of forces which is occurring in the shoulder joint. So the wind up and the early cocking, as for earlier I have mentioned that it is the very shortest phase in the entire throwing cycle. So in the wind up and the early cocking phase, the shoulder joint and the structures around the shoulder joint ligaments are not experiencing any kind of stresses due to the throwing. So we'll tend to move to the next phase. So there is a study which shows the association among the hip and shoulder ROM and the shoulder injury in professional baseball players. So the study done by Sher et al. In 2010 says that the decrease in the hip internal rotation in the non-dominant hip is highly correlated to the predisposition of shoulder injury in non-pitchers. So the decrease in the dominant hip extension is correlated with an increase in the shoulder ER in a non-pitching group. So to say in a simple, hip movements of the hip should be evaluated in a shoulder patient, in an overhead athlete. So whether in the shoulder, the hip movement, rotational movements is directly or indirectly is correlating with the shoulder performance. So the examination of hip is again should be stressfully evaluated. So in the late cocking phase, what happens? In the late cocking phase is actually what in the late cocking phase, the hand is in the extreme position. Hand is in the extreme position of 1980. So your hand will be going in the 90 degree of external rotation and 90 degree of external 90 degree of abduction, and the hand will be going beyond the glenohumeral joint. So the elbow will be going beyond the glenohumeral joint, so which can you see in the image also. So this creates more stress in the glenohumeral joint and around the structures, which create some altered biomechanics. We'll see later one by one what are all the things which are occurring in a phase and what we should focus on in individual, which will be discussed a little bit later in the coming slides. So the late cocking phase, the things starts the strain in the structures, shoulder structures is getting improved than the early wind up and cocking phase. So once after the late cocking phase, the acceleration phase is continued. So before that, the acceleration phase, I would like to show a few evidence of the late cocking phase, which is correlated with clinical conditions. So the Bankart lesion, which is few players experiencing instability or a subluxation. So the instability or subluxation will be experienced most likely in the late cocking phase. So the late cocking phase, the risk of subluxation is started getting high in the late cocking phase. So the late cocking phase, it is itself the direction in the late cocking phase you can see in this radiological image. So in the 90-90 position, which means a 90-degree abduction and 90-degree external rotation, the movement of humeral head. So the movement of humeral head over the glenoid, it tends to get rotated, and there is some translationary force in the biceps also. So the biceps is also getting twisted in the, so the biceps anchor is also getting stretched. So in the late cocking phase, these small changes of biomechanics is leads to disability, the dislocation. So once this late cocking phase, during this late cocking phase, it's in the during this bone-to-bone movement of the humeral head along with the glenoid cavity. So these repeated movements occur once, and it's happening chronically. Once it started occurring in a chronic athletes, there is an bone loss which you can expect in the glenoid cavity. So that anterior inferior bone loss is said as Bankart lesion, and it is there are many studies Bankart. After Bankart, there are many studies are done after all the initial phases. This is the latest evidence which I got in Lin et al. Study. This study also re-emphasizes that during the late cocking phase, the anterior instability of the shoulder is at the highest risk in this position. So let's move on to the next one. So once this significant increase in the activity of long head of biceps in patient with anterior glenohumeral instability. So activity is occurring at 90 to 120 degrees. So the 90 degrees in parallel with the glenohumeral joint, elbow joint is in parallel. 90 to 120 degree means it's going beyond the shoulder. So this is the angle. So once this hyperangulation occurs, there is a significant increase in the long head of the biceps. It's getting stretched, and the biceps anchor is also getting twisted, and it started to pull off from its origin, which is the slap, which is termed as slap lesion. So which we'll be discussing in the upcoming slides. So here we can experience two things. One is Bankart lesion. So and the Bankart lesion is followed by the slap lesion. So the Bankart is the bony lesion, which you can experience the anteroinferior glenoid bone loss, which will be seen here. There are various other types of Bankart lesion as also that there are 7 to 8 types of Bankart lesion is there. So that is apart from the scope of this topic, so we are not entering into it. So this EMG studies is once we started talking about the overhead athlete pain, the rotator cuff is the more common structure which is encountered. In this late cocking phase. In this late cocking phase, we are in this EMG study suggests that in the late cocking phase, the infraspinatus and teres minor show very high activation. The supraspinatus is having least active during this late cocking phase. This is no wonder because the infraspinatus and teres minor are the external rotators. Supraspinatus, the action of supraspinatus is only in the initial abduction. We won't get any activity in the late cocking phase or in the acceleration, deceleration phase. Supraspinatus will be very least active. So only the supraspinatus will be active in the initial wind up and cocking phase, that too in a very supportive evidence is there as supraspinatus. Other than that, the infraspinatus and teres minor are the external rotators as per the anatomical and biomechanical considerations. These infraspinatus and teres minor showing the very high activation, which is also confirmed with the EMG. So, in the late cocking phase, what actually occurs? In the late cocking phase, as I earlier mentioned, there is some adaptations which is happening, and that adaptations which leads to the physiological once this physiological adaptation is reached, so the patient tries to improve his performance. So once this adaptation started, it's stretching to an extent. So rather than increasing the performance, these adaptations tends to halt his performance or reduce his performance. That is the story of every super athlete. So once this physiological adaptations are stretched beyond the limit, so the athlete is able to doesn't able to perform much previous like this previous eras. Other than that, once this bony adaptation starts to occur, what is actually occurring in this late cocking phase? This late cocking phase, this bony adaptations is occurring with the wolf law. So what is wolf law? The wolf law is it's a adaptation. The adaptation once this 1990 movement started occurring. So once this abduction and external rotation movement started occurring, this femoral retroversion and the glenoid retroversion is started occurring. So once this retroversion movement started occurring, so the biomechanics of the glenohumeral joint changes. So the scapular mechanics also started getting changed, and the glenoid humeral movements also started getting changed. So once these changes started occurring, the scapular movements are getting altered. So you should evaluate scapular dyskinesia for every throwing athlete. Scapular dyskinesia is invariably present for, as far as I have looked for in the many professional players. I have noticed scapular dyskinesia, and we have started rehabilitation along with the pain management of the shoulder. This scapular dyskinesia rehab should go into a parallel part along with the shoulder pain. So what is this GARD? GARD is glenohumeral internal rotation deficit. So what is this GARD is internal rotation deficit. The internal rotators will get deficit. As we can see in the image, the internal rotation is reduced, which is showed in the dotted lines. Actual dotted line is the 90 degrees, the parallel to the patient, and the actual dotted line is 20 to 30 degrees is much lesser, which is compensated by external rotation. So the external rotation part is getting more to compensate the internal rotation loss. So this is called GARD. We'll describe this condition in coming slides. So apart from this and Bangkok lesion, there is another condition which is occurring in late cocking phase is the impingement syndrome. So this impingement syndrome is also in another thing which every athlete will experience. So this impingement is again two types: the external and the internal. The internal impingement will occur between the glenoid and the humerals. The glenoid cavity and the humeral head. This impingement started occurring, and most likely the supraspinatus tendon will be the involved. So once this shoulder getting 90 movements we saw earlier. So once this hyperangulation occurs, the supraspinatus tendon is the culprit, which is a victim, which is usually get caught between these two bony structures. And once this once this athlete goes into hyperangulation position, the pain will again come, and he won't able to throw, and suddenly he will start complaining of pain, and then he won't able to throw again. So that is the typical scenario explained by the patient. So once the hyperangulation occurs, he won't able to throw, and then he throws the object down, and then team physio or team doctor will be there, and then pain management will be done. So this is the actual scenario, on-spot scenario, which is happening. And in your clinical consultation room, you can also receive the same kind of history. So once this blade cocking phase, there is one acceleration phase. This acceleration phase is the releasing phase. So once this this is also a very shortest the shortest in the throwing cycle, but very explosive. The explosive forces will be there, and the shoulder structures are again most likely getting injured during this acceleration phase, because in the acceleration phase the body weight is actually transitioning from one position to another position. So in a baseball, it is from the push-off leg to the landing leg, the force is transmitted, and during the transmission also, the ball, once the acceleration occurs, the ball will get released after that. So in this acceleration phase, the latissimus dorsi and pectoralis major are the primary muscle groups which are contributing to the velocity. So these are all the structures which helps to in the acceleration phase. So what are all the biomechanical considerations one should give in during the each kind of the phase? The athlete should be explained about the throwing phase. Phases of the throwing cycle should be explained to the athlete. But what all the things should be in kept in mind. So based on the asking of history itself, the clinician can assume which phase the athlete is experiencing pain. So whether in the blade cocking phase or in the acceleration or deceleration phase. So what in which phase is actually the athlete is experiencing pain? Based on that, we'll see a few considerations. So the acceleration phase injuries are is actually it's a little bit contradictory things what we will actually record, because the acceleration in the throwing phase, what we see is that the acceleration phase is the most explosive phase. So what we think of usually in the explosive phase, the most likely the injuries will occur. That should be the usual way of thinking. Then that is the logic also. But in the acceleration phase, actually the injuries are less in the acceleration phase injuries, because the shoulder loads load is actually less. The structures are getting involved, but the shoulder load is actually less. Studies are still going on, still at this acceleration phase. Injuries are not that much injuries. Relatively, rotator cuff injuries are involved in the acceleration phase. That too also not not severe as compared with any other phase like late cogging phase or in the deceleration or follow through phase. It's not of that much. So the impingement is likely occur, which we saw earlier, the internal impingement phase which is occurring. So that is the acceleration phase injuries, and in the deceleration phase, the is actually there is a shoulder joint is the load is actually peaked during this deceleration phase. So this is characterized by most authors the most violent phase of throwing. So once this deceleration occurs, uh, the what exactly occurs in the deceleration. So you can see you can compare it with Newton's third law. So the Newton's third law is every object is having equal and opposite reaction. So I am looking into a similar kind of thing into this. So once this ball is released after that to counteract the force which the ball is produced. So the counteraction force is occurring in shoulder joint. So this is what I assume that the deceleration phase is more explosive and is characterized. It's associated most of the throwing structures, ligaments and surrounding ligaments and slap lesions around or everyone is likely associated with deceleration phase. The force in the deceleration during shear force are 300 newtons and 1000 newtons are is reported. The EMG studies are also says that teres minor is highly active in this throwing phase, and the scapular stabilizer are also very active. The middle and posterior deltoid are highly active, and the latissimus dorsi are highly active. The deceleration phase, rotator cuff injuries, as we earlier discussed. Why? Because in the deceleration phase, there is some physiological changes and microscopical changes which we can see, especially the dilatation of the transverse tubule and distortion of the myofibrillar components, fragmentation of sarcoplasmic reticulum, lesions of plasma membrane, cytoskeleton damage, and changes in the extracellular myofibrometric and swollen mitochondria. These are all the microscopic changes which you can see in the deceleration phase. The rotator cuff injury, as we earlier discussed, it can be in the posterior impingement occurring in the late cogging phase, and in the subacromial impingement can occur in the acceleration phase. Why both these occur is due to repetitive micro trauma, which is occurring during with the hyperangulation phase. The slap lesions. The slap lesions, like in the deceleration phase, what happens in the force is reduced and the force is getting transmitted during the deceleration. So once this biceps is getting stretched, biceps tendon is stretched. Once this biceps tendon is stretched and the forces is transmitted through the biceps tendon, and the force is transmitted till the origin of the fiber, origin of the biceps. So once this till that, once this these changes, repetitive changes, once started occurring, you can experience tear in biceps also. So that is in the form of slap lesion. There are 4 types of slap lesions. So the type 1 is simple fraying and degeneration. The type 2 is fraying along with detachment. And the type 3 is a bucket handle tear. The type 4 is a bucket handle tear, which is extending into the biceps tendon. So there are other slap lesions also. Slap lesion is actually 10 types. So for we are not going in depth into it. We are looking into only 4 types. So the slap lesion, why the slap lesion is occurring? So the slap lesion, there is a mechanism. So during the repetitive traction, so once this repetitive traction occurs, during this deceleration phase, this instability occurs. Anterior glenohumeral instability occurs. This mechanism is called a peel-back mechanism. The peel-back mechanism is occurring during the late cocking phase, and the mechanism is simple hyperangulation. Once this shoulder is getting set, you also experience the same. So once this hyperangulation occurs, you can feel a tightness in the posterior shoulder structures. And this posterior shoulder structure tightness is actually pulling is a pull, and the anterior structures are getting stretched. So in the posterior there is a pull, the anterior there is a stretch. So there is an imbalance. There is a tug of war between these two structures, and there it's you can visible in the form of a slap tear. So that is the peel back mechanism, which is explained, which can be explained in simpler terms. So we can see the rehabilitation part. So once the clinical evaluation part is done, we are entering into rehabilitation part. So what are the shoulder structures?
Dr. Praveen, we have 2 minutes, sir.
Yes, sir.
And
We'll
wind
complete
up.
it. Yes, sir.
Okay.
So apart from the shoulder part, we are evaluating the hip, core, and anterior chest and thoracic extension part. Overhead mechanics also we should try to evaluate. So there are 4 stages of rehabilitation: acute, intermediate, advanced, and the RTP phase. So the acute is the pain and inflammation phase. We try to control the pain and inflammation. Analgesics, anti-inflammatory can be a part. Apart from that, isometric exercises, proprioception exercises is the major mode of intervention in this acute phase. So once this acute phase is done, we are entering into intermediate stage. In the intermediate stage, and program is there, which I will explain in the next slide. Apart from that, core and hip strengthening and kinetic chain integration part can be done. The Throist program is it's explained beautifully in Bruckner and Kahn. Can also refer there. Bruckner and Kahn, I have taken the 3rd edition. So the basic rotator cuff training, followed by the functional Haber position is abduction and external rotation position. And once this Haber position occurs, you should increase the load in the Haber position. And once the load is increased in the Haber position, you should increase the speed in the Haber position. So after that, functional throwing and deceleration phase of that, and you should focus on the eccentric strength of the external rotators and focus on the deceleration muscles, posterior shoulder structures, followed by the stretch shortening phase of the throwing. So which is the plyometric part. So the advanced phase, it is also likely an throwist and extension. So RTP will, so this is the phase 4. So when will we allow the sports medicine physician should allow the athlete to return to play? So there should be a side-to-side difference of minimum of less than 20 degrees in GARD, and the total ROM should be less than 500, 5%. The normal strength is less than 10% of the throwers, and annual dynamometry 75% of the minimum should be there. And you can measure the internal external rotation ratio of minimum of 66% should be there. And you can examine the normal scapular function and the functional ability of the shoulder, which you can test with the medicine ball throw test, Y balance test. This can be done, and this RTP criteria is also taken from Buckner and Khan. You can take a picture of it and keep it with your mobile once the patient is getting visited to a clinic, so it will be easy for you. So yes, apart from that, these are all very small things which you should keep in mind during the individual conditions. What are all the rehab part which you should focus? For a posterior impingement, you should focus on rotator cuff and scapula strength. And hyperangulation, you should focus on the modification of the hyperangulation should be there. So the overuse conditions also is that you should look for a slap lesion, you should look for the throwing mechanics like that. This lap lesion, you should focus on these structures which is mentioned earlier. The hyperangulation and the rotator cuff strengthening stability is there. And yes, in the subacromial impingement, you should can follow this 5-step program. Abstain from irritating activities for 10 days. Normalize shoulder unilateral motion, capsular mobility, and focus on the scapular strength during the retraction and the gradual return to throwing phase. Thank you. Thanks for providing this opportunity, sir.
Thank you, Dr. Praveen. Can you just unshare your this thing?
Yes, sir.
I'll just remove your share this thing.
Yes, sir. Yes, sir. Yes, sir.
Yeah. Thank you, Praveen, for such an enlightening document in detail about everything. So I thank you, and all questions, if any questions are there, please put it in chat at the end of this session. Like we have 3 speakers, we will just club it together and we can ask questions. And if time is not there, then we can individually later come to it, and I'll definitely send it in our members group. We'll go to the next speaker, Dr. Chetan. Dr. Chetan did his MD Sports Medicine from VMMC Safdarjung, and after that, he is currently the Sports Medicine head for IAS JSW, where he deals with all top elite athletes. So I thought that there is no better person who deals with athletes at a high level and at an elite level to speak on hamstring, because that is one of the major injuries. Over to Dr. Chetan. I'm not taking any more time because we are going at correct time. So, but still, Dr. Chetan, you have the floor is on. Can you increase your volume? Dr. Chetan, I can't hear you. If you can increase your volume.
Hello, can you hear me, sir?
Yeah. Now
it's better now.
Yeah.
Okay.
Yeah.
So can you see the slides?
Yeah. We can see. You can just enlarge it. You can.
Okay, thank you. And good morning, everyone. And thank you for ISSEM Society to give an opportunity for this seminar. And so first thing is, my topic is pulling a hammy, a clearance to play, and how to decide. So when coming to the hamstring, it's not easy because there is a high recurrence rates and recurrence rate of re-injuries, and also there's a different protocols they follow and different factors we consider when it comes to especially RTP. It may be different types of injury. I will not go too deep into the different types of injury, mechanism of injury or rehabilitation. I will straight away go to a RTP because within that, I think 30 minutes is not sufficient, but I will try to keep it as simple as possible. So first comes the question is, who decides RTP? So previously it was sports medicine physician or a team physician was a gatekeeper for RTP. What you mean by that is once everything is done, once the rehabilitation done, once the strength, adequate
Doctor,
strength is done.
sorry to disturb. Dr. Chetan, your video, can you enlarge it? We can just see the PPT, only outside.
Okay, just a minute, sir.
Yeah. Can you just enlarge it? Right now it is showing like, the whole PPT. If you can, no, now the sharing has.
Yes, sir. Just a minute, sir.
Yeah.
So there is some issue with the enter share. Yes. So can you hear me? Can you see the entire slides now?
Yeah. Now everything is right.
Okay.
Yeah. Everything.
Okay, thank you. Yeah. So
And
what I
just
was
keep
saying is,
sorry, can you keep the volume like that? Because in between it goes down. So this is right.
sure. Okay, sir. So who decides
Thank you.
RTP? Yeah. So previously it was a sports medicine physician or the team physician was a gatekeeper. So what it means is once you're done, you have finished your acute phase and the rehab phase and the strength and conditioning, everything and sports specific training, everything is done. The sports medicine physician was the one who was used to take a call. Okay, this person is currently fit. He can go for a competition or he can start with a full training. So, but nowadays it is more of an interdisciplinary approach. What is interdisciplinary approach? As we go along, I will explain you. So who all include in this interdisciplinary approach, including that team physician, of course, and the sports physio, strength and conditioning coach, sports psychologist, and sometimes coach as well. So coming to the how to decide on RTP, it is still we do not have exact answer for this, but based on the expert opinion, based on the clinical evidences, and based on a practical evidences, these are the things we consider when we decide on the RTP. That includes similar hamstring flexibility, absence of pain and palpation, strength testing, performance on field testing, and functional testing, and also acute chronic work ratio, psychological readiness. So coming to the first is what is similar hamstring? You can check on the different tests that includes active knee extension test, passive knee extension test, passive SLR, or Askling H test. So we need the basic thing is we need a stable couch and also we need an inclinometer. And what we check is we have to test for a maximum tolerable stretch and angle measured using an inclinometer with a horizontal plane. So what is currently we say is it should be between anywhere between 0 to 10% of difference compared to pre-injury level. We consider okay, this criteria is ticked. But again, we cannot exactly tell okay whether the 10% will mean 0 to 10 is completely allowed, because every degree there's a deficit, there is always associated with a re-injury risk. But however, the common consensus is that which we may not never achieve 0 degree difference, so we keep it 0 to 10% difference. So as I said earlier, like there are different kind of testing. The most commonly used test is passive SLR or active knee extension test. In the first picture we can see where it's a passive knee extension test, and they're keeping the inclinometer on the anterior part of the leg and then see the difference. Usually we have to measure all the baseline test baselines like flexibility, especially if it's a football, especially coming to the hamstring. The more common extensive study has been done in the football, because lower body injuries are very, very common, and especially hamstring is very common in a football. So what they do is usually in the preseason, before starting a season, they do a baseline checkup that includes flexibility, strength, concentric, eccentric, isometric strength. So they check and then note down, okay, what is the SLR, passive SLR, active knee extension test. And coming to a second picture, I'm showing dynamics flexibility H test. So what it shows is like the confidence. How we do it is we just tie, we make sure the knee is completely extended. We fix the pelvis, we fix the contralateral knee, and then we tell the athlete first we do passive extension. Then we tell the athlete to do 3 repeated fast SLR, active SLR. And after that, we note down what is a VAS scale. So that will give us an idea, okay, what is the confidence the athlete has? Is there any pain? The flexibility, is the issue is still persist? If it's significant, then again, it will give us no. So we cannot further progress. If we think, okay, he's compared to bilaterally, he's doing well, and the VAS score is also less, that suggests okay, this first criteria is we can go ahead. So we'll go for the next one. And what is the single most important is the symptom free. What do you mean by symptom free is absence of pain or discomfort and palpation. Again, this is a very subjective matter. What is subjective matter means, by example, I'm an physician and I'm examining. If I'm pressing too hard, of course the athlete gonna feel pain. Or if I'm pressing too light, even there is a pain, I cannot elicit the pain. So it is over and over time, like you will know what is the pressure, approximate pressure. So yeah, there will be a variation all the time, but still if the athlete is saying, even athlete knows actually sometimes when they press, because they're in this field for a very long time, they know if they feel a discomfort, they will tell you at this exact point I'm feeling pain, and they will tell you, okay sir, you can press a little hard so I'll feel it. So over a time you'll understand, and based on each athlete also you can see, and also you can take some inputs also from the people who are working day in day out. For example, you're not seeing the athlete regularly, you can take an input from the physio as well. They could also give an input like based on the discomfort and the pain, especially in the palpation, because commonly in a soft tissue release everything will be done by the physio, so you can take input from them. Or if not, if you're with a regular contact with the athlete, you can also elicit the based on your experiences. Yeah. And absence of pain during strength and flexibility testing, this is also very important criteria, because you cannot tell the athlete to push during the rehab phase, especially during the rehab phase, just to assess strength and flexibility even with the presence of pain. So first criteria is, before going for a strength and flexibility testing, the pain should be minimal. If not zero, at least it has to be minimal. And absence of pain after functional testing. So if you do any testings and the next day the athlete comes with a saying, okay, I developed a severe pain, that suggests, itself suggests he's not ready to for the higher activities. So that is also no for RTP. So before considering, okay, this guy can be, this athlete can be considered for RTP, this is very, very important symptom. Important criteria, that is absence of pain of palpation or a discomfort, or absence of pain during strength and flexibility, and absence of pain after functional testing. Why I'm saying this is, it is observed that there's a 4 times higher risk of re-injury with athletes with an pain on palpation to absence of pain. That suggests, like, if I'm sending 4 athletes at the end of RTP, like 4 different athletes, 4 groups. In the one group, I'm sending an athlete with the pain on or a discomfort on palpation, and the other 4 are absence of pain. So there is a more likely, like 1:4. That is the re-injury risk. So it is too high. So this is one of the significant independent predictor for the re-injury. So coming to the third factor is strength testing. So there is a lot of mixed opinion in the strength testing. So as we know, there are different kind of testings, but most commonly we use is isometric, eccentric, and a concentric. Nowadays, concentric, we are not using any concentric testing because it has not shown any significant association or nothing with the RTP or the re-injury or any progression in the rehabilitation. So we mainly stick on to isometric strength and eccentric strength. Again, eccentric strength, many experts says it do not have that much value, because what they believe is that strength measure is not functional, because it's just a one parameter, and also asymmetry is also very normal, and too many factors are involved, so there's a less reliability in the strength testing. So they prefer more of a functional testing. However, from our point, we consider isometric strength usually at the end. Main can be checked at different angles. Most commonly we do at 15 degree, and the 90 degrees are most preferred, and literature also says 15 and 90 is the more preferred one, especially 15 is more reliable. So if there's any significant difference, first say we do isometric testing, it's showing 20% difference, and even the hamstring testing, other testings are okay, the functional testing is good, but still having 20% isometric strength difference is not ideal. So that time maybe you have to work on, even though it is not a significant factor to say RTP, but still having more than 20% is not ideal. So if there's anything less than 10%, you also say, okay, there's a less risk of re-injury, we can go ahead. If there's anything between 20, we have to work on it, maybe we have to delay the RTP. And coming to the same with the eccentric strength, it was done under isokinetic at a 60 degree per second. Again, what I prefer is, if there's anything between 0 to 10% of a difference, it is ideal. But if it's more than that, again, you have to take a call based on the other testings. But isometric, I prefer taking isometric as at least consider isometric, if not eccentric and concentric. This is one of the biggest parameter out of all for the RTP. That is like performance on field testing or functional testings. So nowadays there are significant improvement over the last few years that's like a GPS targeted match specific rehabilitation. Because when you can see in the picture, the athlete is wearing a vest, so it will track down everything: the acceleration, deceleration, the top speed, how much is the load, how many minutes he has run, total distance covered. So it will change in direction. So it will give us all the data. So I'll explain in the coming slides what all the data we get from the GPS, how we can use that during the rehabilitation or during the RTP or during just prevention of hamstring injuries. So next is a repeated sprint ability test. Again, it depends on the protocol, different athletes. I mean, depends on the sports. We do a test at a different meters and the seconds. But most commonly used is it is a one I'm taken from football, because as I said earlier, football is the one where extensive study has been done on the hamstring injuries. So that is 20 to 30 meter. We do a dash, 6 sets or 6 repeat, 20 seconds of rest in between. So we calculate the overall time and it will give us a data. Okay, currently this is the state of the athlete. And again, after this, athlete should not be getting pain, or if they're getting pain, again we're going back to the rehab. So again, this has to be compared with the pre-injury level. As I said earlier, like when the athlete comes to you before starting a season, or when he's good without any injuries, we assess all the tests. So we keep the baseline data, and whenever there's an injury or whenever during the competition or whenever you think there is a high chance of injury or whenever there is a sudden increase in load, we compare these tests. So give us idea, okay, where athlete stands currently. So coming to the next one is single leg bridge and deceleration drills, acceleration drills, T-test, 40-meter sprint. So again, different protocols are used. These are the more common, but experts, according to the literature, the top 4 that position GPS targeted match specific, repeated sprint ability tests, single leg, and deceleration drills, they voted these are the better performance testings. Okay, as I was saying earlier, the GPS gives us all this detail that includes total distance covered at high speed running, distance covered sprint running, number of accelerating efforts, number of decelerating efforts, maximal speed, individualized moderate speed running, individual high speed running, individual speed running, and etc. So again, it is not a, here you can see distance covered sprint running more than 25.2 km per hour. Again, it varies between the age, sex, and the type of sports. And this will give us a like what is the total load. And I'll come to the next one is control of chaos continuum. So what is this chaos continuum is? It is what we usually do during the rehabilitation. So rehabilitation, it will be divided into 6 phases. I mean 6 phases in the sense control to chaos continuum, where after the initial management we go to the next, that is where there's a different 6 stages that includes high control, moderate control, control to chaos, moderate chaos, and high chaos. So what it does is, before we plan for RTP, these are the stages here athlete has to go through. Again, it has a different session load, sports scientist information that includes type of running, type of activity you want to do, and coach information, because coach also has its input, like what are the drills you want to include in that, and the number of sessions that gives us a volume and session overview. So like a different specific sports specific activities. So once we start, okay, high control, we give some time, then we see, okay, the athlete is doing good, then we go to the moderate control, same to the control to chaos, then to the moderate chaos, then to the high chaos. So these all can be tracked if you're using the like a GPS. So we can track down to the almost, if not 100%, at least close to that. So we can say this is the athlete load and he's tolerating and the progression is good. So after that, once we have a progression, once we know the calculation load, for example, let's say he did up from the last 4 weeks, the load was this much, 800 units or something. It depends on the sports again, 800 units. And we know, okay, at end of the 4 weeks, we say, okay, athlete is cleared from all the criteria. So we can say, okay, this athlete is now ready to go for a full match. And at the same time, we're going to ask a coach, what going to be the load at the next as soon as he comes to the return to play at that week, what's going to be the load? If the coach says some high numbers, it's going to be like, as I said earlier, it's 800 for last 4 weeks, but suddenly the coach says probably it's going to be 1,400. That is a significant difference is there. So there we're going to use acute chronic work ratio. So what is this acute chronic work ratio is? I will take a small example of a fast bowler in this. Just imagine there is a fast bowler who had an hamstring grade 1 injury, grade 1 or grade 2, and he rehabbed for between 6 to 8 weeks. And now he's in a RTP phase. So in the last 4 weeks, in an average, he was bowling 120 balls in a week. And we take the RPE. What is the RPE? Rated perceived exertion. So he give you around 10. So we multiply that RPE with the total number of ball bowled. So it will come at 120 into 10. That is equal to 1,200. So at the end of RTP, we ask the coach, now we feel the patient is, the athlete is fit to come back to sports. And the coach says there's a test match coming up in the next week. So then we're going to ask the coach, what is his expectation? The coach says probably he will be bowling 140, 150 balls. So then we calculate the rated perceived exertion based on the sports physical, like kind of fast bowler he is, what is the pace, everything. Usually it is handled by the strength and conditioning and the coaches. So they will tell me, okay, the load gonna be 1,500. So if I see 1,200, 1,500, there's only 1.2% change. Though this is safer. That's why there is a green sweet spot. You can see what it suggests is, if you compare the last 4 weeks and the coming week, it should be between 0.8 to 1.3. Then we can say, okay, there is a low risk of injury. But whenever it increases beyond 1.5, that is, for example, he's bowling 120 balls per this week, suddenly he's bowling more than 180 ball in the upcoming week. So that suggests there's a significant increase in the load. So that is 1.5. You can see the curve, suddenly the curve increases. So this is also one of the RTP criteria. You cannot just say, okay, now he's fine, he's having a pain-free, strength is okay, and the load is okay, whatever we think is fine. Suddenly you take him, and you cannot push him for the maximum. So you should know what is the upcoming week. And also we should discuss with the coach, okay, this is the maximum load you can give. If you think we can manage with that load, then only you select him for the upcoming matches. Same with the football, same with any sprints. If he's not reached, if he's in a danger zone, then you have to explain to the coach and to the manager, to the athlete, that you come in the danger zone. So it's not going to be the easy. There's a high chance of re-injury, especially when it comes to the hamstring, because hamstring has shown significant re-injury rates. I will explain you in the next coming slides. So these two slides are very important. Control to chaos continuum. So this will give us, it's mainly help us in the rehabilitation and also at the RTP, and to calculate the load and the acute and chronic work ratio. That helps us the re-injury rates, and also when to push the athlete. So coming to the next one is, as I said, psychological consideration. So this was not previously that important, but nowadays it's getting, every athlete also complaining of that. And also we also feel, yes, we also need to stress on the psychological considerations. So what are the characteristics athlete show when he's psychologically ready? Is realistic expectations. He knows his expectations and he tell you like, okay, I know currently what I'm feeling. They will explain, and you can feel it like, okay, athlete is in a right space. And the same high level of self-efficiency and low level of anxiety. So this will be better picked up by a sports psychologist. And how can be like, what are the factors that include is personal factors, contextual factors. Personal factors will be like a goal, is type of personality and all. Contextual includes coaches, the performance level, and the personality trait, treating sports medicine staff, and where exactly, for example, if it's the IPL or it's big season, what is the impact athlete can bring. So many factors comes in, but again, it will be better like if it comes from the athletes and the coaches, it would be easier to assess more than from the sports medicine physician. And what are the 3 key important factors in this is monitor the athlete. So how do you monitor? There are different tools, that IPRRS scale. What is IPRRS? Is injury preparedness for injury psychology readiness for return to sports scale. So when there's a scale, I will show in the next picture what all the factors, things we consider in the IPRS scale. And also we can use a POM scale, or intellectual profile of mood state. So this is one factor. And the second thing is subjective evaluation. So if you know the athlete, you can tell, okay, if you're in contact with the athlete regularly, if the psychologist talking to the athlete before injury, during the season, after the injury, and when they is close to RTP, so they will be knowing, okay, what is the state of mind, whether it's psychological fit or not. Because here the subjective evaluation matters a lot compared to other all. Here the subjective evaluation is very important. So having a close knit of psychology and the athlete bonding also helps. And the second thing is adapting to the interdisciplinary. And the things that comes under the RS goal is there are 6 items, and you tell the athlete to score between 0 to 100, and at the end it will become as out of 600, then you divide by 10. So you will get a score between 0 to 60. So you'll see the improvement. Like what was his score like before, just after the injury, or during the rehab phase, just before RTP, after the RTP, and after the first few matches. So what he's feeling, so it will give us idea like how he's progressing. Whenever there's a red flag, whenever you think, okay, it's going down, drastically down, then we have to pull out the athlete. So I'm coming to the MRI. There's a lot of discussion on the MRI. Should we use MRI for the RTP decision? I'll explain it. Usually we do a 2 MRI previously. One is a baseline MRI. Baseline MRI is just post-injury. They used to see what is the severity of injury, extent of injury, and to get an idea of the expected period of rehab. But over the years, there's a lot of study has been done, and every study has shown there is nothing significant association with RTP and predicting re-injury. So whether it's a grade 1, grade 2, whatever how much is the edema, how much is the signal intensity, it has nothing to do with the RTP, and also nothing to do with the predicting re-injury. Yes, compared to RTP, if there's a significant injury, maybe you can say, okay, in the earlier there was a significant muscle disruption, we can delay for some days, but end of the day, we are not taking any further MRI to decide on the RTP and MRI at RTP. So in one study, it has showed 89% showed muscle edema signal changes at the time of RTP. So where RTP means, except the MRI, other criteria, everything were met, and clinically the hamstring were recovered, still the MRI was showing 89% of muscle edema. So this shows that there is no association with that. And also, like over a time, like even following up post RTP also, there is no significant association between MRI and the re-injury. So baseline MRI will be good enough, and MRI at RTP, I don't prefer, but again, it depends on the situation. If there is a high stake athlete, and also there are a lot of medical legal conditions and a lot of answer you have to give to the management, then yeah, you can plan. But for the per se of RTP, there is no need of MRI, especially. So, and recently there was a discussions among hamstring, and the common consensus, these are the criteria they excluded from the RTP criteria. That includes similar concentric hamstring strength. As I said earlier, it is not that functional, so they excluded the concentric hamstring strength. And the MRI, yes, we discussed, and completion of number of full friendly matches and completion of number of full training sessions, because these two actually comes after RTP. So previously, whenever some coach comes and says he's doing good, he has done 4 sessions in the last 2 weeks, he has done a good, that doesn't tell me, okay, he's good to go for RTP, because these things comes actually after once the RTP is cleared. So they have excluded these 2 things, and the neuromuscular function, because it is very vague and also very difficult to assess. So they have taken the neuromuscular function out of the RTP criteria. So coming to the re-injury, as I said, the hamstring is the one where it has shown higher re-injury rate, very significant. In fact, it is 12 to 33% of re-injury within 1 year of RTP, and sometimes in some study it has shown up to 60% re-injury within 2 years of RTP. So that is very significant. And recurrent injuries require more extensive rehabilitation than primary injuries. And then more than 50% of a re-injury occurs within the first month of RTP. So there is a question mark, like, is it because of a premature RTP? Yeah, probably it could be because of the premature RTP. So what are the things we can consider in that is the control to chaos continuum. It will give us okay, where athlete is, to calculate the load, and we can apply the acute chronic ratio, so that it will give us what the risk percentage, whether it falls in the safe zone or in the red zone. So it will give us idea. Of course, it will not completely eliminate, but it could help us in reducing the re-injury rates. And also there's a previous injury is an undisputed risk factor for a future injury. If the athlete has a one previous injury, less likely to, he has a lesser percentage compared to the person with the two injuries. So we have to be very careful. Preventing hamstring injury is one of the important, especially in a sprints, football, any dash, any sprints. And also we have to adopt START framework. START framework is that it's not just specific for the hamstring, for the anything. So we have to consider what it suggests is strategic assessment of risk and risk tolerance. So it has a different steps 3. So first step comes under, okay, what you just assess the patient demographics, symptoms, personal medical history, science tests, and all the things. So whatever I explained, it all majority comes in the step 1. So we have to assess in the step 1. Once the step 1 is clear, then we'll tell, okay, we can go for the step 2. There we'll assess what is the position, what is the limb dominance, what is the type of sport, is there anything we have to do sport specific, or something we can have to prevent. So that comes in a step 2. But here in the whole of my seminar, I was just restricted to step 1. So once the step 2 is done, then comes the step 3. Step 3 has a lot of different variables. That is where the season, type of season, pressure of the competition, external pressure, masking the injury, conflict of interest. There's some, so what the money also involved, so many medical legal things also involved. So for us as a physician, mainly our role comes in clearing the step 1, and partly for the step 2 and step 3, it's a completely majorly, I don't say completely, it's a majorly athlete, coach, and the external factors. So coming to the independent predictor for re-injury, there is a 4 times more likely to sustain a re-injury compared with the athletes with the absence of discomfort on palpation. So whenever clearing an RTP, make sure there is no discomfort or minimal discomfort and a pain on palpation. And also there's a 33% increased risk per number of previous hamstring injuries. As we are discussing earlier, yes, we have to decrease the re-injury, and also we have to try to prevent injuries. And then there's a 13% increased risk per deficit in degree of flexibility. As I was discussing earlier, there is a 0 to 10% is allowed. But again, every 1%, 1 degree flexibility loss, there is a chance of 13% increased risk. But again, this is normative data, still not proved. And we don't know the population. There are only few studies with a very few athletes. So we need more and more research on this to know exactly what is the flexibility range we need, what is the exact risk per deficit in the degree of flexibility. Currently, 1 or 2 studies has shown there is close to around 13% risk per degree. Same as for the 4% increased risk for deficit in Newton. Again, 4% is still less, and also, as I said earlier, strength, it's a very one parameters, and it's not that reliable. So we can go for a isometric just to see whether a significant difference is there. So if it's a significant, then we can delay the RTP. So yes, at the end, I did not get a good photo. I tried to get a good interdisciplinary photo, but yeah, this is the maximum I could do. So yes, so there's a sports physician, and we need a physio, we need a psychologist, we need a coach, and we need a strength and conditioning coach, and we need an athlete, and sometimes we need to include a manager also to decide on the RTP. But as a physician, as I said earlier in the start, so our role is to mainly clear the step 1 and to assess a little bit in the step 2 and a very minimal in the step 3. But always we have to be open about it. Whatever the literature, whatever your personal experience, whatever the athlete need, all 3 has to be combined together before going to the RTP, and we have to prevent the further re-injuries. And thank you very much for giving this opportunity.
Thank you, Dr. Chetan. That was a wonderful presentation. It was very compact and it was very well put. I'm sure we have a few questions that I'll be putting it at the end of this session once Dr. Deepak's talk is completed. We have a few questions for Dr. Praveen also. So I'll go to the next speaker. Thank you, Dr. Chetan, for your talk. It was an amazing talk.
Thank you.
We'll get back to you.
Thank you, sir.
So we'll go to the next speaker, Dr. Deepak. Dr. Deepak is I've known him since from before when he was doing his MBBS itself. At that time itself, his one of his peak, he wanted to get into sports medicine, and I still remember him coming and asking me what is sports medicine and how to go about it. So he did his PG dip in IS Patiala, and after that he has been working with football teams. So he's worked with Kerala Blasters, he's worked with Mumbai Indians, he has worked with Hyderabad FC. So there is no better person to speak on travel sports medicine, which I thought was something which, you know, as a team doctor, you need somebody with experience and who's been doing it for the past few years. So his topic is on pre-travel preparation and approach to obstacles you face as a team doctor. Dr. Deepak, I'm putting the stage on to you. You can start.
Thank you, sir, for the very elaborate introduction. First of all, I would like to thank ISSEM.
Can you increase the voice a little bit? It's a little bit
yes,
down.
sir. Am I audible?
Yeah. Now it's on.
Yeah. So, first of all, I would like to thank ISSEM for allowing this opportunity for me, because I remember maybe around 3 years back, 3 to 4 years back, I was part of the organizing committee back then. But then right now, I am quite happy that I am in a position wherein I can talk about this. Right now, we'll start with the discussion. It's a small, trying to share my top, like my PPT here, but I'm facing technical trouble. Just a minute. Okay, but basically, I was asked to talk about the challenges faced by a team doctor and how it. So I actually asked about to discuss and talk from my personal experience about being a team doctor and the challenges that I had to face, and also regarding pre-travel preparations. So first of all, I was fortunate enough to have three seasons. I worked 3 seasons with 2 different ISL teams, and I was fortunate enough to have one COVID bubble season as well as 2 regular traveling seasons. And I was also able to travel abroad with the team for AFC Champions League games. That was to Saudi Arabia. And I was also able to travel within the team within India for the league. So basically, I had divided my topic of discussion of four headings. The first being the COVID biobubble season, basically. So first of all, the main thing that I wanted to talk about in the COVID biobubble season is the.
Dr. Deepak, can you see the?
Yeah, I can see. Thank you. Okay. So first of all, we'll go to the first slide, which is the COVID biobubble life. So first things first, having an action plan is what is very important for a sports medicine doctor, because always you expect certain problems to occur, but you should always have action plans in place for problems that you are also not really expecting to happen. So while we were in a biobubble wherein we had to live 6 months together within a resort, all the team members, our technical, non-technical staff, the players, as well as the hotel staff, we all stayed together. We were only allowed entrance into the resort. Then we were able to go for training, come back from training, and go to the stadium for matches. The stadium was empty, no fans. Then come back. So only these 3 areas we had access to. So it was done with so much preparation to decrease any COVID cases being happening within the COVID bubble. And we were at times tested almost 3 times a day with 1 RT-PCR and 2 RAT tests. So the COVID action plan basically from the league was supposed to be foolproof, but we always expected that in case pandemic happens within the bubble, like if our outspread happens, what should we do? How can we contain it? Uh, in a hospital setup, we always have the freedom to isolate this person, isolate this person. In a football situation where we are having matches every week in week out, or maybe at least every 4 days or 3 days, quarantining someone all of a sudden is not something that is practical. So we have to be, being a sports medicine doctor, the biggest thing I think we have to understand is that we have to be flexible enough to not always go by the book, but not too flexible so that we don't have any set restrictions on ourselves. So we have to manage it and be flexible so that at the end it's a performance-based industry, and you are able to help your club get maximum performance out of the players. So having a COVID action plan did help us because unfortunately we did have a COVID outbreak within the bubble, which did cause us some issue, but we were able to manage and we were able to play the games. So first things first, being in a COVID situation, it was the first experience for me, but having a COVID action plan in place helped a lot. Then about food and personal hygiene. So in a football team right now in India, the sports medicine team consists of a sports medicine doctor, 2 or 3 sports physiotherapists, and 2 or 3 sports masseurs, depending upon the sports medicine budget of the team. So at the end, the doctor is the only person with a medical background. The sports physios do help out a lot. Someone with an emergency room experience is usually the doctor alone. So you always think that your job should be or will be restricted to just being a doctor for the team, for the players. But at the end, you will always have shared responsibilities where you will have to go beyond your job description at times. So as I was just starting, it was my first year as a sports team doctor. We were about to start the league. I was very excited regarding that. But 2 days before, on match day -2, I wake up and I have a upset stomach. I call up my sports team to tell them like, okay, I won't be able to come work today. I'll have to take rest. And to my surprise, all the members in the medical team are sick. All the technical staff are sick, all the players are sick, all the hotel staff within the hotel are sick. Of around 50-60 people who were staying within, more than half of them have fallen sick. There was a widespread food poisoning. So a widespread food poisoning 48 hours before the first match of the league, and we were playing the host. We were playing Goa at that time. So that was a huge challenge wherein I was also not feeling well, but I had to take care of the team. I had to take care of the players. I was taking pills myself, but going about giving medicine to others, taking care of their hydration, taking care of their nutrition, because prepping the players mentally as well as physically for the first game was very important. So that was one experience or one challenge that I didn't expect to happen on such a large scale at the beginning. But that was an experience wherein I became, because we were staying in a resort and not like a 5-star hotel or anything where there used to be regular, there'll be a food hygiene officer, but unfortunately our setup didn't have one. So I had to be a makeshift food hygiene officer, wherein I used to go to the go to the kitchen where the food was made, where the food was being brought in from outside, to see how the hygiene was maintained, so that this episode doesn't happen again. And because I was doing that on a regular basis, fortunately we didn't have another episode. But at the end, you have to set standards of hygiene. You have to, that is for even for food or for personal hygiene, and you have to put yourself out there and take care of those things. You would prefer in an ideal situation for a hygiene officer to come in and do it, but in a COVID bubble wherein you are the medical person, there is no one else with enough background to push through the hygiene standards. You have to take it up. So that was something That is something I feel all sportsmen and doctors should be understanding, that you have to be very flexible at the situation and take up roles which may not be written on your contract or which may not be something you are comfortable, but which will help with the performance of the team. And then the next thing I would like to talk about is the travel restrictions and how it affects the mental health. So we, as I said earlier, we were given access to, we would just get out from our rooms in the resort, get on a bus, go to training ground, train, get back on the bus, no interaction with anyone, come back to the training, come back to our stay. Then on match days we go to stadium, empty stadium, no interaction with anyone, come back to our stay on the bus. So it was a very hard time mentally, I would say, for everyone, not just the players, all staff, to stay in this situation. We had a beach access, but it was not a private beach. So our access was curtailed for majority of the 6 months we were staying there. So at times, just whenever we got access, everyone would go to the beach and have a look at the sunset going down. This would seem very simple, but when you're playing games and game in, game out, the mental fatigue that builds in when you have to play every 4 or 5 games, and when the results are not going well, you have to reset yourself. And this doesn't just involve the players, it involves all the staff, because when you start working in a football team, you're part of a family and you end up being very emotionally and mentally involved, and each match day becomes draining, mentally and physically also. So getting a restart button in between is very important. And because of the situation, and because the because of the scenario, see, an ideal scenario, there should be a sports psychologist with the team, because at national and international level, mental toughness is what makes the difference between being an international athlete and a national athlete. But unfortunately, till now, the sports science department hired is quite limited. I hope that changes in the future. But because I had minimal training in sports psychology, I used to undertake counseling sessions, and I used to also help players who wanted with sports psychology exercises to my limitations, of course. And I would have definitely preferred having someone with the team as a sports psychologist at that point. But so I had to do that part also, and that also showcases how flexible you are or you can be, and that also helps with building a lot of rapport with the players. So not just staying on your core subject, but being able to go into areas away from your core subject which might not be very comfortable is something I think all sportsmen and doctors should look forward to. Then working under limited medical infrastructure. So because of the bubble situation, the rule was that if anyone, be it a player, be it a technical staff, whoever goes out of the bio bubble, if he has to go out of the bio bubble for any reason, be it medical or personal, he or she would have to at least undergo 14 days of quarantine to get back in. So this will seriously affect the plans of the coaches, plans of the team when games are coming thick through, coming fast. So I was at times very much under pressure to work under very limited infrastructure. We had a medical room, like it was a makeshift medical room within the resort, and the infrastructure was quite less. So I think that is another challenge as a team doctor you will face, because with the usual doctor training that most of us receive, wherein we are accustomed to working in emergency rooms with almost everything that we need at disposal and enough manpower to back us. At the end, in this situation, the sports physios who I have worked with have always been very helpful and have always supported me to their maximum capability. But at times, you end up having to do a lot of things as a single person, because there is not enough manpower available at the site. So, and very little medical infrastructure available. So you have to work through it. You have to, be able to make up cut corners at times, but it is a give and take. So the next thing is traveling abroad with the team. So we had our AFC Champions League games in Saudi Arabia, and because it was an AFC based game, we were very fortunate because AFC helped a lot with the travel logistics, especially with our medical equipment, the medicines, and everything. But even if you're not traveling for such a tournament, if you're traveling for an exposure game or if you're traveling for preseason, you will have to take up all these responsibilities on you, and that is something you have to always plan ahead regarding, because you don't want to go to a foreign country and then you end up not having enough things to take care of the team for maybe 1 month or something, how long you're staying there. So deciding that, pre-planning that is very important, and always not just from the medical point of view, from the physio point of view, from the masseur point of view, from the whole sports medicine team point of view, you have to be always prepared, because local purchasing is always an option. But in the Indian scenario, the almost all the clubs work with a very limited medical budget, so you always have to think about that. And the second thing is local organizing community and local networking. So wherever you're going, be it a federation a tournament or be it on your own with the club, having a very good personal contact with the local organizing committee, and also making local networks, local contacts even before reaching the place will help you in many ways, because that has helped me when I was traveling with the team. So these are very small things, but things that will help you when you are in a situation of emergency and things really don't work out. So that is very important. And third thing that I want to focus is we traveled during April in 2022. So it was during Ramadan. So few of my players were also fasting at that time, and we reached Saudi Arabia like 2-3 days before Ramadan. So that was fine. But as soon as Ramadan started, the hotel that we stayed in, they were kind enough to provide us a separate room, and they also provided us separate meals just for us, just for the team during the Ramadan time. But the nutrition becomes hard at that time for the fasting players as well as the non-fasting players. So you have to understand the player, but also make sure that we are able to recuperate them enough so that they are strong enough during training, they are fit enough during the matches, and decrease the injury concerns or the injury risk regarding, because nutrition is very much affected during the Ramadan time. Sleep is very much affected during the Ramadan time, and we have to find ways where the player is also comfortable, but it also doesn't affect the training or the match schedule. And trying to optimize their nutrition and sleep at that time is also something that is not very easy to handle. So you have to make sure you take care of that in a very personalized way. Next thing, next I would like to talk about team travel within India. So we always feel that travel within the country is quite easy, or is quite straightforward. India is a very vast country, and I definitely feel that one time zone doesn't do justice to it. Even if you travel from the western and to the eastern. So regarding that, the change in climate is something you have to be always be concerned about. We had issues while traveling to Delhi per se because of the air quality in Delhi. We had issues when we were traveling from Hyderabad to Chennai because of the difference in humidity, sudden difference in humidity, which does affect the sweating, and you also have to ask the players to adjust their hydration as well as nutrition likewise. And usually I would always prefer traveling on match day -2. That is the best time and the best way to best way to travel medically. That is a very personal opinion, but the decision depends on the coach and it differs from coach to coach. We usually used to travel on match day -1. So match day -1 used to be a very long day. We used to start the day for me used to start at around 6:30. We had training that day. We do match day -1 training. Then we have our lunches. We get ready. We go to the airport directly from the training ground. We travel all the way. Then we reach the destination at times by 8 p.m. At times 9 p.m. At times 10 p.m. So you can't expect that. So match day -1, when it becomes a travel day, you always have to take care of the nutrition of the players. You also always have to keep informing the players about inquiring about their nutritional status. Make sure that they are being fueled at the right time, even during those time, and after also reaching the destination. See, being a team doctor, the working hours are have to be very flexible. Match day -1 days, I have had days where I woke up at 6 a.m. and went to bed at almost 12 at night or even 1 night. So you have to be flexible in that aspect. And traveling is something you always think is exciting, but when you're traveling for work, you barely get time to like you're traveling for work. You don't get time to visit the place, but rather you almost spend most of your time at the hotel or at the airport. So being ready for the travel day, be planning in advance for the travel day, and also being ready for any medical emergencies during the travel is also very important. So from that aspect, you have to be ready for that. Then, as I said, sleep and nutrition, because so many of my players used to have sleep issues on match day -1. Most of them have had anxiety issues on match day -1, so they are not able to get proper sleep. So you have to take care of them at times, even medically. So that is also very important. And I think nutrition is something that is very lacking even at the topmost level and could be improved. So there are in a team there are players who are just popping into the scene, and there would be players who are 10, 15 years on the field, and they have the experience with that. So you have to pick and choose whom you can help out with. You have to pick and choose who would benefit from it, because you cannot just go in and all of a sudden change the routine of a player who has had a set routine for the last 10, 15 years. So you have to think about that and always have backup plans. We have had a situation where we were supposed to fly in a late evening flight, but then it got postponed. Then it was match day -1. Then it got postponed again, delayed, and finally the flight was cancelled. We had to fly early morning on a match day. So this just throws all the sleep cycle, all the nutrition plans, everything. It just throws everything in the bin. So then you have to make backup plans to make sure when and where and how the training the schedule of the player would be, so that they are at an optimum with respect to nutrition and sleep. I would say nutrition and sleep is the hardest thing to get right, and if you are able to get that right, which are very basic but very hard to get right, I think almost 80-85% of the recovery is already done in that. So we'll go to the next slide, which is the challenges that I've faced as a sports medicine doctor and regarding the sports medicine team. So first of all, as I said, it's a teamwork. You have to be a team player. The sports medicine team, the chemistry within the sports medicine team, the chemistry within, let's say, the sports medicine team, the sports science team, the strength and conditioning team, the management, the technical stuff. It has to be on point for the team to perform optimally. And when you are in a situation where you are, my reporting authority for the sports, my reporting authority or the sports medicine team's reporting authority are rarely people who are from the medical field. So you have a gap that's there that you have to bridge. and that can be bridged, but you have to put in an extra effort to be able to bridge that gap so that the whole team works seamlessly. So team chemistry is very important. Maintaining the team chemistry when you're working for almost a season right now is around 10 months. So you are working with the same group of people, living, traveling, and working with the same group of people for almost 10 months continuously, where some results go well, some results go not so well, and then you have to manage the morale as well as the overall mood of the medical team as well for the optimal productivity from the sports medicine, which is very important. So you have to be a team leader there. You have to be someone who is able to gel everyone together. That is very important as a sports medicine doctor. I would say like that those are parts like parts of being a sports medicine doctor who has to improve his communication skill, who has to improve his administrative skill. Then, as I said, action plans, always having action plans, always having emergency action plans in place, wherein what if such a thing happens on field? What if such a thing happens during training? What if such a medical emergency happens while traveling? How do you address it? How do you counter the problems? And you also have to exercise the action plans on a regular basis, which is not always possible, but at least make sure push your team to exercise protocols. Emergency response protocols on a regular basis is very important. And then, as I said, the sports medicine team, the sports doctor, the sports physiotherapist, the sports medicine, we are all cogs in a bigger wheel, and we all have our we can all make a difference to the team and the team's performance, even though it will be small when you look from the biggest perspective, but your effort will definitely help maybe bring back a player maybe before RTP, might help a player perform more than he can, or there are like will be helpful in preventing injuries. So these are small things, but at the end of the season, these all things add up. And for me, to assess how good you are able to work depends on how many injuries you have prevented compared to the previous season, and how many days the player has lost because of injury. If you are able to decrease these numericals, I think you are able to make a difference to the team's performance, and being able to monitor these things and being able to project these things to the management is very important from a sports medicine team perspective, because we have to make sure and understand that the Indian scenario is still adjusting and adapting to the concept of a sports medicine team and the importance of the sports medicine team. So making them understand how important it is also critical for the development for yourself as well as for others. And lastly, what I would like to talk about is player education. See, player education is something that most of us would feel not mandatory, and because there is already so many responsibilities on you, you end up thinking that maybe that is not very important, or at times you might think that okay, if I give out information to a player regarding these things, then he might not come back to us. But in my personal experience, that has not been the case. You should always try to educate the player, be it from a nutrition point of view, be it from be it regarding supplementation he is doubtful about, be it regarding like sexual hygiene or personal hygiene. All those things are very important, very small things, but are important if you're able to educate the player rather than, thinking that maybe if I give out information, I will lose my value. That should not be the right way to go about. So I hope this session has been something that has been really helpful for everyone. If you have any doubts or any concerns, please do reach out to me. And thank you once again for ISSEM and especially Dr. Siddharth sir for giving me such an opportunity. Thank you.
Thank you, everyone. Thank you, Dr. Deepak, for his talk. It was quite enlightening, telling us about all his experiences and what he went through. Because these things cannot be explained, means cannot be taught. And Dr. Deepak has wonderfully, um, put in what and all he has experienced, and hopefully this is helpful for all the young juniors out there who's watching this video. So I've got a few questions. We'll just go to the question and answer session. Just a few questions to Dr. Praveen, Dr. Chetan. I'll start with Dr. Praveen. Dr. Praveen, if you can come unmute yourself and come to the video, I can ask a few questions. Two questions which was asked in the YouTube and separately to me through WhatsApp. Dr. Praveen, are you there?
Yes, sir.
Yeah, can you just on your video, please?
Yes, sir.
Okay. Yeah, Dr. Praveen. So I'll just ask the question. So one of the questions which was asked to me was which phase, according to you, means you gave different phases based on the throwing, this thing. Which phase has the most injury? Means which you would say that you have to be really careful if you take one phase. Is it the deceleration phase or is it the acceleration phase? So which phase would I have to take care? Which phase which you have to be
take
most
care of deceleration followed deceleration followed by the leg cocking phase is the most common thing which we have to look for. Deceleration is the first.
Okay, so deceleration is the first, which is the
Yes.
most common. One another question, which was this was personally messaged to me. How do we differentiate an AC joint involvement compared to a shoulder pain? How do we differentiate? Is there any special way which we can differentiate between whether an AC joint is involved, or say a slap or a tendinitis or a tendon tear, rotator cuff? How do we differentiate between those
So
two?
for that, we have to check for each individual structures. We have different tests. For example, for slap, we should look for some O'Brien's test. We have to look for AC joint. Simple palpation is enough for AC joint, and if needed to rule out, we can check for an X-ray whether there is an AC joint involvement. We can check for an X-ray also, and we can look for the coracoid process also. If there is an involvement of type 1, type 2, type 3 acromion process, we have to rule out whether that can cause impingement. So for that, for like those kind of conditions to rule out individually, we have to assess them individually according to the condition.
Okay. Okay, Dr. Praveen, thank you. I'll
Thank
come
you.
to Dr. Chetan. You're there, right, Dr. Chetan? Yeah. So one of the question was that is there any difference in RTP, return to play, for first time acute ham injury or an acute, a chronic repeat injury? It has again become acute. So is there any specific delay in return to play for that? Your volume is off. Your volume is off. Means it is low. Can you just increase the volume? I can't hear you, unfortunately.
Now it's fine.
Yeah.
Okay, actually there is no difference between, yes, the only thing is the consensus is that primary acute injury will take comparatively lesser time, lesser rehab before RTP, and whereas chronic or acute on chronic will take more time. That is the only consensus is there. Otherwise the rehabilitation plan, the everything, the criteria for RTP, everything is the same.
Okay. Another question which was asked is there any specific test which we can do on field? Say, for example, there's a meet going on and the person had a small hamstring, or a football match, and there's a hamstring, immediate small pain is there. So how do you, during a match immediately, how do you can predict whether he can continue or not? That was one of the questions which was asked. Is there
Sure,
any
yeah.
specific test, or how do you, as a sports medicine physician, take the decision at that time?
So with that, actually on the field side, it's very limited actually. We cannot do much on the field side, especially when the athlete is just came out from the competition, because the body is warm. We cannot exactly assess the extent of injury, especially in the acute stage. But whenever you, as a physician, what we do is we do for the basic test as a flexibility and isometric test, basic 15 degree. If there's a significant difference between the right and left, and the isometric change, and also we do a MET, muscle energy technique. And with that, if the athlete is complaining of pain, then we have to take a call. That time it's very subjective. We cannot go with very objective. And also nowadays we can have a ultrasound at the field side also.
Okay.
So that is, yeah, it's advanced. If you have accessibility for the ultrasound, you can do it, check. It will take only 5 minutes for that, and there's no muscle edema, there's no signs of tear, and then we can take a call. But even with the imaging is not a gold standard. At that time, it's a physical examination, the tenderness, and there's a disruption of, you feel any disruption of fibers and the severe pain or any discontinuity, and you're not able to continue walk, limp. These are the things we look for. If there's anything, then we have to take out the athlete.
Okay, thank you, Dr. Chetan. These were the two questions which were asked. I'll come to Dr. Deepak.
Thank you.
Dr. Deepak, there's one question for you, two questions for you as well. One question was, this is not to do with football, but in, say, for example, in a marathon, if a runner, how much fluid is to be given during pre-competition? Is there any restriction, or how much you can advise us how much fluid is to be given, means to be consumed by the athlete right before the marathon?
Okay, so hydration, as I said, is quite important. Also, how long the marathon is and how long the effort will be is also important in considering how much fluid has to be given. First of all, we always have the set criteria regarding the body weight and expecting upon the sweat rate of the athlete. We have to decide how much fluid as well as electrolyte has to be given prior. One main problem that usually happens with marathons, especially in amateur marathon runners, is overhydration. That is something we have to be very sure to avoid. So usually 30 minutes to 1 hour, 30 minutes before any kind of workout exercise, 500 ml should be given, and usually it is around see the expected weight loss that happens after a workout exercise into 1.5 times that. So if you lose around 1 kg, you give around 1.5 liter rehydration. That is after workout, and always before that, make sure that you do a regular osmolarity check to make sure that the athlete is hydrated regularly. So 3 to 4 liters per day with every workout intensity more than 1 hour, you give around 500 to 1 liter, wherein you always make sure there is almost a 3:1 ratio between pure fluids as well as electrolytes would be quite adequate. But as I said, it varies from person to person, varies regarding the sweat rate, it varies if the person is a salty sweater or non-salty sweater. So all those things have to be taken in consideration.
Okay. This is one last question which was asked to me was doping in football when you are traveling with teams. So how do you ensure, means do you give sessions in between, or is it a separate thing in ISL? How does it happen? Means not testing part, but education. Does the team doctor have separate classes, or how does we make sure that the athlete does not consume anything out of the ordinary?
So in a in a year, always at the start of the league, NADA does hold a session, an online session for all the players as well as staff regarding doping, doping violations. But to be frank, it is almost a 1 hour session, and usually taken at a very medical point of view, and most of the athletes do not understand it. So usually after the session, we usually go to the player. We usually keep a list of the supplements the player usually takes. We educate the player regarding what all medicines they are on regularly, how much they are supposed to take, and we keep a very close eye on all of these things on a very regular basis. Because ISL has had few doping issues in the past, in the recent 2-3 years. So there is still a very high problem of inadvertent doping, wherein players, because they are around 10 months, we have a season, 2 months they have an off season, they go back to their hometown, where always a team doctor is not available. They go for over the counter medications, wherein inadvertent chances of inadvertent doping is always there from cough syrups and all those things, which would seem very basic, but it is still there. So you always have to be in touch with your players even during off season. Keep educating them about things which they get over the top. And regarding the other things, we usually have in-person sessions with players regarding education, because during a preseason where it is already packed with so much training session, at times 2 training sessions or 2 ground sessions and a gym session, you don't really get a time to put in a education session. So you have to make time for it. When the player comes to maybe for a treatment or something, you talk to them in person, or when they have an off time, you talk to them in person, try to educate them. And that is basically it.
Okay, thank you, all the speakers, Dr. Praveed, Dr. Chetan, Dr. Deepak. Thank you for your session. It was wonderful. We'll go to the next topic, which is sports science and nutrition. This is a very interesting topic where I'll go to the first speaker, Colonel Anup Krishnan. There is Colonel Anup, I think, has been in sports medicine for some time. For the past 23 years, he's been serving our nation, and he did his MBBS from Bombay University, then he did his DSM, and he completed his PhD in sports rehabilitation, and is currently doing his PhD in sports medicine. So that shows itself his acquirement of knowledge is quite high, and he really wants to bring the best out of him. One of the most important thing is being the honorary sports medicine consultant to the President of India for 2 years, and he has several publications and presentations, and the list goes on and on of his accomplishments. Currently, sir is the director and professor of School of Sports, Exercise and Nutrition Sciences, and consultant sports and exercise medicine of D.Y. Patel Sports and High Performance Center at D.Y. Patel, Navi Mumbai. Sir is going to speak on the recovery techniques in sports, the science behind. Over to you, sir.
Thank you. Am I audible?
Yes, sir, you're audible.
Okay. Thank you, ISSEM. Thank you, Dr. Siddharth, for that wonderful introduction. So I'll be speaking on recovery techniques in sports and the science behind it. I will also be giving some recommendations depending upon what is scientifically given, and also some anecdotal evidence and something from my practice also. So recovery is an important aspect of exercise training, as it's an integral component of the overall training program and is essential for optimal performance. If the rate of recovery is improved, higher training volumes and intensities are possible without the detrimental effects of overtraining. There are several variabilities which is there within the recovery process due to the training status, fatigue, and the ability to deal with the physical, emotional, and psychological stresses. Jeffries in 2005 defined some components of recovery. He defined it as normalization of the physiological functions, return to homeostasis, restoration of energy stores, replenishment of cellular energy enzymes. So recovery, as we know, is a complex process, and it may include an active component and a passive component. What is the importance of recovery in sport? Recovery in sport allows the body to repair damaged tissues, replenish energy stores, reduce fatigue, and restore hormonal balance. A well-structured recovery regimen enables athletes to maintain consistent performance, avoid overtraining, recuperate mentally, enhance skills, and reduce injuries. We know something called types of recovery. There's something called immediate recovery, which occurs during the exercise itself. There's something called short-term recovery, which includes recovery between the sets of a given exercise or between the interval of the workout. And there is something called training recovery, which is the recovery within workout sessions or competitions. Recovery strategies can be classified based upon the type of applications into passive recovery, wherein the body recovers through external stimulation; active recovery, which involves voluntary activities like jogging, walking, stretching, etc. And proactive recovery, which involves self-initiated and social activities. Recovery strategy can also be classified based upon the moment of application into immediate recovery, that is recovery occurring between short-time movements; short-term recovery, which is basically the strategies which are used between the training sets; and training recovery, which focuses on the time between consecutive training sessions or competitions. And this plays a vital role in the restoration of muscle and liver glycogen. So when we talk about recovery strategies, I will label these as the big three, and sleep, nutrition, and stretching. So there is no doubt and there is no argument regarding the importance of sleep, nutrition, and stretching. And there is a lot of scientific study which has gone into all this. So we will not be dwelling too much into the importance of all this. So the big three are important, and it's only a very brave sports medicine doctor who's going to go against the convention and not prescribe sleep, nutrition, and stretching. When we talk about recovery, we should be aware of something called the recovery pyramid. Items which are towards the bottom of the pyramid are to be prescribed more, and items towards the top of the pyramid are to be prescribed in a lesser manner. So this is how the recovery pyramid looks like, and sleep, nutrition, hydration, water immersion, compression, massage, cryo, EMS, pads, etc. So items towards the bottom, prescribe more; items towards the top, prescribe less. When we talk about something called the hierarchy of scientific evidence, this is very important because we're going to talk about evidence in recovery. So the strongest evidence is meta-analysis and systematic reviews. And as we go down the pyramid, the level of evidence or the quality of evidence goes down. All right. So let's come to recovery strategies with a high level of evidence. Foam rolling. It is a form of self-myofascial release, aims to increase the range of motion at the joints, relieves muscle tightness, and reduces muscle soreness and inflammation. Okay, so what does the research say? There are quite a few meta-analysis and reviews on the topic of foam rolling. Strongly indicates that foam rolling is an effective method of improving range of motion following exercise. A review of 49 studies reported that foam rolling reduced DOMS and increased pressure to pain threshold and may optimize recovery from training. And the optimal dose to gain the ROM benefits seems to be 90 to 120 seconds per muscle group. There are a few studies which have shown that increased range of motion or decreased DOMS translates to athletic performance following foam rolling as part of a recovery strategy. Okay, so what are the recommendations? Foam rolling is a cheap, portable, and a practical solution, and every athlete should own a foam roller. There are several post-exercise benefits to range of motion and DOMS, and the psychological benefit of a foam rolling session is immense. So, thumbs up from our side. Sports massage. Now, sports massage or massage therapy is rarely used due to its inaccessibility and expense. It is similar to myofascial release as it targets fascia, it targets muscle tension and soreness. The massage techniques empty the venous beds, attenuate cytokine production, and there is a psychophysical response of increased relaxation. What does the research say? A very well conducted meta-analysis examined the effect of massage on performance. It found no influence of massage on restoration of jump and strength endurance, and a very small improvement in endurance and sprint performance. Now, be aware that this is efficacy on performance and not efficacy on recovery. However, the studies that showed performance benefits utilized massage immediately prior to the second exercise bout. That means they utilize massage as a recovery massage. What is the recommendation? We should know not all massage procedures are the same, and different routines have different effects, and the response to the routine may vary from person to person. Athletes with increased muscle tension and or reduced mobility may see benefits in performance following these effects. Compression garments. Big business and the manufacturers claim all sorts of recovery benefits such as reduced muscle oscillation during exercise, increased blood flow, increased removal of metabolic waste, increased proprioception, reduced inflammation and swelling. What does the research say? A meta-analysis of 23 studies reported that compression enhanced recovery after more than 24 hours of post-resistance exercise, and compression garments might aid in next day endurance performance, particularly in cycling. Another systematic review of 183 studies reported potential increases in arterial blood flow, reduced muscle oscillation, improved proprioception, and reduced perceptions of muscle soreness and pain following exercise. What is the recommendation? Compression will improve perceptions of DOMS and feeling of recovery, and it is likely not to do much of harm. It's a relatively inexpensive strategy that can be used in any post or during exercise setting. Photobiomodulation. A PBMT using either a low-level LED or a low-level laser is being recently used by professional athletes. There has been plenty of research on PBMT. However, athletes have recently started using this. It modulates the biological processes of cells at the mitochondrial level, increasing oxygen consumption, production of ATP, while also reducing inflammation and attenuating DOMS. What does the research say? There are a few different meta-analyses which report positive findings for PBMT, especially to reduce muscle fatigue and increase both muscle strength and endurance performance. A recent meta-analysis also suggested that PBMT might be more effective than cryotherapy, that is cold water emulsion or ice pack application. What do the recommendations say? If you look at the studies of PBMT, you will find that most of the studies in this area come from the same center or the same group of authors. However, PBMT does seem to show promise as a recovery strategy for athletes. There is a center which has been recently opened in Bombay, in New Bombay specifically, and we are working in collaboration with them, and we are getting good results with PBMT. So yes, it does seem to show some promise. However, more high-quality research from multiple lab groups is needed to corroborate the findings of the initial groups. If the facility is available and if you're looking for an extra edge, please use it, because if nothing, the novelty factor might give you a placebo effect. This ice baths and cold water immersion. Probably one of the most common researched and used recovery strategies. It reduces muscle soreness, reduces inflammation after exercise, and promotes blood and fluid shifts within the body. What does the research say? Several meta-analyses and reviews on the topic tend to support their use as an acute post-exercise recovery strategy. The general recommendations for temperature and duration are 10 to 15 degrees centigrade for 10 to 15 minutes. However, recently this has become a controversial topic because a lot of caution has been emerging about ice baths. So emerging research shows that chronic ice bath use after resistance training may have a negative effect on the muscle and it may blunt some of the adaptations. However, there is a minimal impact following aerobic exercise. Recommendation: we must use it, there is no question about it, but please periodize it into a full recovery program based upon the training phase. Even just being in the water can be a recovery strategy by swimming in the beach or in a swimming pool, because the hydrostatic benefits of immersion in water are often overlooked when we focus so much on the temperature of water. Now let's come to the recovery strategies with a moderate level of evidence. EMS, NMES, or electromyostimulation or neuromuscular electrical stimulation. You place electrodes on the muscles and you give different current forms with the aim of inducing muscle contractions so that you increase the muscle blood flow and improve the metabolite. What does the science say? Systematic review of 13 EMS studies reported that only one study showed a performance benefit and 3 showed a benefit of reducing muscle pain. A review of 11 studies reported similar findings, though they suggested that protocols are varied, electrode placement sites are varied, and the frequencies and the intensities of the studies are varied. So it is difficult to draw any concrete conclusions. What are the recommendations? More quality research is needed on the newer devices. Devices are costly, so if you have other recovery tools available, use them. However, they are portable and they are practical. So in case you're looking for pain relief rather than recovery, please use NMES. Cryotherapy changes, WBC or whole body cryotherapy. It involves short exposures between 2 to 4 minutes to very cold air, -100 to minus 100 degrees centigrade, in a controlled room or chamber. Usually you have 3 chambers of increasing temperatures. And it is commonly used to relieve pain, particularly in inflammatory diseases, injuries, and overuse. It accelerates recovery, decreases muscle damage, and inflammation markers. What does the science say? The science says a lot about this actually. A series of small randomized studies found WBC offers improvements in subjective recovery and muscle soreness following metabolic or mechanical overload. However, it did not seem to translate into functional recovery improvements. Another review from 2017 identified 16 studies and reported that muscle pain decreased in 80% of these experiments. 2 studies found recovery of athletic capacity and performance, and other benefits of WBC, which included reduction of inflammation and lower markers of muscle damage in the blood. Some studies have shown that cold water immersion may offer comparable physiological and performance recovery benefits to WBC without the associated cost or practical consideration. Recommendation: availability is limited. So because it is costly and it is impractical and it cannot be moved. So in our settings, if you're traveling with a team or something like that, then it is of limited utility. However, if it is available, please use it, if nothing for but the placebo effect. Athletes can obtain similar benefit with other strategies at a fraction of the cost. Recovery boots or sleeves. Intermittent pneumatic compression, dynamic compression, sequential compression, you name it, there are several names for it. They are basically limb sleeves that exert high levels of pressure and inflate and deflate in a massage-like action. Improves blood flow and venous return to reduce metabolic waste and muscle soreness. Actually started as a medical device to reduce the lymphatic swelling, but now it is being used by athletes also. What does the research say? There are no systematic reviews or meta-analysis available. However, the majority of studies report benefits to perceived muscle soreness, fatigue, and recovery, with mixed findings on the actual benefit to athletic performance. Recommendation: there are some benefits to perceived muscle soreness and fatigue. If a massage therapist is not available, it can be used as a viable alternative. And they are a portable and practical tool which can be carried, and it does show some promise. Athletes seem to like it. Recovery strategies with a low level of evidence. Float tanks. Now, this is something called a flotation device or a sensory deprivation tank. This used to be used mostly in the military setting, but now it has come into the sports recovery and the athletic setting. It is basically a device in a tank where there is a saline solution. It is at skin temperature. So when you lie in this solution, you feel sensory deprived and there is a relaxation response. What does the research say? There are only a handful of studies on the topic. These studies report promising effects of floating on perceived muscle soreness, blood markers, fatigue, mood, sleep, and some performance measures. The initial reports are encouraging, but more research is needed to confirm the findings. Recommendation: if available, please use it. There is plenty of promise in this. And the main benefit may come from the enforced rest and relaxation and switching off from the world for a short period of time. It's a psychophysiological recovery tool that athletes either love it or hate it. So if your athlete likes it and if it is available, please use it. Massage guns, percussion massage therapy. It proposes to improve range of motion, decrease muscle tension and soreness, and increase the blood flow. A lot of people are also using this to treat trigger points. It's become one of the most used yet least researched recovery tools of the last few years. One study showed an improvement in range of motion following the massage gun use, with no improvements in subsequent performance. Another study showed benefits for restoring muscle compliance and reducing stiffness. One study reported a case of rhabdomyolysis following the use of a massage gun. Recommendation: use with caution, because most of the available evidence is anecdotal. Blood flow restriction, BFR training. Now, BFR training was a popular training tool, but it is now being used as a recovery strategy. It uses cuffs or inflatable devices to induce periods of vascular occlusion, followed by reperfusion, and has been proposed to improve vasodilatation, oxygen utilization, muscle function, and recovery following exercise. What does the research say? There are some studies which are reporting positive effects and others are reporting no effect. However, a meta-analysis of just 6 studies reported some improvements in performance recovery, as well as reduction in CK levels and muscle soreness. Recommendation: again, strategy shows promise, but more research is needed. When we talk about recovery aids, there's something called a belief effect, which you should be aware. They make you feel better, and that is consistent across most of these recovery gadgets and devices. While the research may not always show a benefit to physiological, biomechanical, psychological, or performance markers, more often than not, if you use these strategies, it will result in perceived lower levels of muscle soreness, pain, and fatigue due to nothing but the placebo effect. And if you feel that there is a good placebo effect, please use it. Because if your athletes believe that something will help them feel better, they probably will. How do you decide what to use and what is the road ahead? Many of these devices and modalities seem to have some positive influence on recovery, while others show little benefit or are inconclusive, requiring further research. Lab-based research evidence is only one consideration for a sports medicine specialist, because to gain an advantage over the competitors, sometimes practitioners need to trial untested strategies. Hold this thought, I'll come to it further. Even if a strategy shows negligible recovery benefits, if the athlete believes that the strategy works, then it probably will, and you should probably use it. This is an algorithm which is given for how to decide on recovery aids for the athletes. There are several questions which you have to answer. Is it legal? Is it safe? Is there a chance it could improve recovery or performance? Is the strategy supported by sufficient research evidence? Does the athlete believe in this efficacy? If you answer these questions using this algorithm, and it is easy to decide how to use or when to use a particular recovery strategy. This is a summary from our clinical sports medicine by Karim Khan. So it gives a short summary about what is the modality, what systems are influenced, and the recommendations in short. So this can be your take-home message. Yeah, I told you to hold that thought. Now, this is an article published in the Medical Journal of Armed Forces India. I was the principal investigator for the study. When this device came to us, we were all very, very skeptical regarding the utility of this device. However, the device proved us wrong. So, and it showed a good performance benefit in anaerobic sportsmen with a substantial benefit in aerobic sportsmen. The paper is available. You may like to go through it. So my point is, keep an open mind and do not neglect something just because you don't think it is scientific. Keep an open mind, try it, conduct a study, a scientific-based study, and if you feel it is effective, then start using it. All right, so what's your take-home message? Recovery is becoming increasingly important to the high-performance athlete in a bid to reduce fatigue and enhance performance. Common recovery techniques include hydrotherapy, active recovery, stretching, compression garments, and massage. There has been a significant increase in research examining both the effects of recovery on performance and potential mechanisms. Recent research suggests that hydrotherapy, compression, and massage can enhance acute performance when utilized appropriately. SEM doctors and athletes are encouraged to experiment with various recovery techniques to identify useful, individualized recovery strategies. These also cater for mental recovery and try and avoid recovery. I seem to have finished, ladies and gentlemen. Thank you very much for your time and patience. I'll be glad to take any questions if the moderator allows. Thank you very much, and Jai Hind.
Thank you, sir. Sir has finished right on time, and I can't say, you know, it's such detailed, and with all the studies, it's been an excellent talk, and I'm sure that all of you will definitely agree with me that this was one of the most useful talks on recovery, which a lot of people always asks questions about it. So at the end of the 3 talks, we will have questions. There are 2 questions which has come to me. So if Anup sir can stay till the end, we'll definitely ask. We'll go to the next. Yes, we'll go to the next speaker, Dr. Amol. So Dr. Amol is a sports medicine doctor, and he did his DSM from PGDIP. PGDIP from Patiala. After that, he has been with multiple teams, especially with the boxing team, because I still remember all his videos and photos in the beginning. He used to post quite a lot. He's a passionate advocate for health and performance, and he founded the Sports Next revolutionary sports EdTech platform. And now he's on a mission to empower everyone through active insight. It's a one-stop solution for achieving optimal health and well-being. Outside of work, Dr. Patel enjoys exploring new ideas, reading and swimming, and he is on a 100-day challenge, which I've been following every day. I think it's on day 94, I think, if I'm right. He's been doing it quite actively, and that's what a sportsman doc has to do, to show that we exercise as well, and to be an example to others. Dr. Amol's topic is on weight cutting and considerations for nutrition sport in combat sports. I thought this was an essential topic because this has not been followed through, and combat sports is growing quite big in India, especially with the growth of MMA as well. So I thought definitely who better to speak on combat sports and on weight cutting and nutrition than Dr. Amol. The stage is on to you, Doctor. Your volume is low. Can you increase your volume, please? It's still low. Volume is still low. No, it's not. Yeah.
Hello?
Yeah. Now it's audible.
Okay, let me share the screen.
Yes, please.
Mhm.
Yeah, it's.
Yeah. Good morning to all, and thank you, Dr. Siddharth, for a wonderful introduction. I'm also thankful to the ISSEM, that is Indian Society of Sports and Exercise Medicine, for giving me this opportunity to talk on one of the important topic today, that is weight cutting and considerations for nutrition support in combat sports. This topic is, very dear to me because I've been working with one of the combat sport, that is boxing, and I often saw, there has been some myths among the athletes, even the coaches, and we had to educate them on and off in the field, off the ground, and it took a lot of time and energy to bring them to the scientific basis of weight cutting, and not just for sports medicine, but I think it is the important topic for all of us who are into sports, or even for the people who are into the wellness industry, who actually want to cut down weight, who are utilizing some of the modalities for various modalities, including exercise and different workouts for reducing their weight and coming to the target goals of fitness. Without wasting much time, I'll just start with the basic thing, that is the energy balance, and I hope that you all know about it. But just to recap before we start the actual topic, that energy intake and energy expenditure ultimately determines what would be the fate of it, whether you will be saving the energy, whether you will be excessively consuming the energy, or you will be just maintaining the weight. And I'll come back to this particular thought once in my presentation in next few slides. But just for your information, and we are summarizing here, that is total energy expenditure by a person is summation of the energy required for basal metabolism, the thermic effect of food, which is obtained after the digestion, and the physical activity that we do. It includes the basal activities as well as the exercise or the sport, anything, whatever we are doing. And therefore, this is an important slide. I feel that if you understand this, and this is a very simple concept, so anybody can actually think of what is required. So you know that energy intake is from the calories that we consume from eating, whereas the expenditure is on that is on the basal metabolic rate, the activity that we are doing, and on addition to that, the exercise that we are doing. I already explained that. But if the energy intake is more than the energy expenditure, obviously you are going to retain some part of it, and that will be in form of the weight. So that will be a weight gain. If you want to target weight loss, obviously you have to do a opposite to that. That means your energy intake will be less than the energy expenditure, and if we want to do it in scientific basis, that is what we are going to discuss about it today, then we have to keep in mind that how much restriction of energy should be there and how much expenditure should be there, so that we are not landing into a overtraining kind of thing, or inviting troubles for various nutritional deficiencies, various problems associated with relative energy deficiency states and the negative energy balances, which might affect the individual at various levels. So before that, the topic was related to the combat sport, and let me define the combat sport for you all. So basically, here any combat term is referring to the sport where competitors engage on one-to-one combat with a specific rule set. That is, you fight, you compete within particular rule set, and that's why it is different to different combat sports. Now, such sports may involve various techniques like striking techniques like punches and kicks, grappling techniques like chokes and joint locks, and a mixture of both striking and grappling techniques. And the sports are classified based on these three things. I'm not going to go into the detail because I suppose that you all know about it. This was just to recollect, because each of the sport has its own challenges, and it will be very difficult for me to say that I have some experience here in combat sport, because I just worked with one of the sport, that is boxing.
Sorry
when I was
to stop. Is your slide, have you switched the slide, or you are just giving an intro? Because slide is not showing, it's just showing the first slide alone.
I'm so sorry. Let me just see the thing. I'm just ending the show. Dr. Siddharth, can you see my slides?
Right now, I cannot see the slide. I can not see anything. I can just see our WebEx, this thing alone.
I'm so sorry. How to do troubleshoot for this?
Can you try it once more?
I'll just try it. I'm just trying it once more. I have just shared the entire screen to be shared precisely. Can you see my screen right now?
Yeah. Now we can see. Yeah.
I have.
Can you enlarge it?
Yeah, I have scrolled it, and can you see it right now?
Yeah. Now we have
the one weight gain, weight loss thing.
Yeah.
Okay, so yes, we can move on from here. That is, we defined what is combat sport, and now we are just looking at the examples that are that combat sport comprises of. It involves sports like boxing, fencing, karate, kung fu, jiu-jitsu, kickboxing, mixed martial arts, judo, wrestling, and taekwondo. Most of these sports are Olympic sports, and some are yet to come into it, but each sport has its own challenges, has its own demands, and it will be very difficult for a person to have a mastery in all these sports to but the general principle remains the same about the weight kitting and the maintenance of ideal weight. That would be same throughout all the sports, majority of them. However, there might be some challenges based on the rule set of that sport, and those need to be explored on individual case basis. When we talk about weight cutting, it's a common practice which we see amongst the athletes. It involves a lot of risk factors, and when I say that, it is when I see the prevalence about it from the literature that we have, it is about 60 to 80% of the competitive combat sport athletes report to go for weight cutting practices before the tournament begins. The time between the weighing and the competition may range from up to 2 hours to 24 hours, depending on the sport and the level of competition. However, these practices are almost one or less same, and therefore it involves a lot of risk factors for the athletes, which needs to be understood. Now, there is a dilemma between us that whether there will be an increase in performance or there will be huge effect on health. And here we have to balance the risk versus benefit ratio when we are deciding the strategy for cutting weight just before the tournament. So what would be the potential performance benefits? Some of the athletes and the coaches and major, in the high performance domain believe that there would be a significant, what you can say, benefit in the lower weight category, especially for athletes who cut down a significant weight and then compete in a category one down or one level down, and therefore they might have some advantage in the strength as well as the muscle size and strength of the the person, in case if you're talking about boxing, the boxer or maybe a wrestler, and that can give him a added advantage. However, there are certain risks which have to be looked for. That is, the athlete might go into dehydration state, there might be electrolyte imbalances, there might be muscle loss if the things are not monitored scientifically, and so on. So, what should be done? What we as sports physicians should be doing? We have to guide these athletes towards safe weight management practices. And that's why we are discussing this topic today here on this forum, where we want to spread this message that we doctors are knowing about all these things, that how the safe weight practice can be done, how safely weight can be cut down. And if you have any problem, do come to us for professional opinions and we will be helping you out. And that's the important message that would be delivered from this platform. Obviously, we all are working collaboratively with the athletes and the coaches to develop the personalized plans. The main focus is athlete well-being and athlete health, just to maintain his career, just to support his sporting career, whatever can be done within the limits of his health and well-being. We are there, we can figure out the strategies based on the evidence-based literature available and the experience that we have, and thus can help these athletes. What does the evidence say about these weight cutting practices? And I have included some of the literature things in this screenshot, and you can see that majority of the literature, if you go through it, will agree on one important fact, that yes, there are a lot of problems which are associated with a rapid weight loss on the day of competition or on the day just before the competition, if it is involving a significant percentage of body mass, that is more than 5% of the body mass, and majority of the literature will agree on it. And then there are certain things which are linked to the performance, whether it will have a benefit or whether it will have a negative outcome, how the effect of weight cutting would be there by different modalities. So I have included one meta-analysis as well, where it compares the different methods, and the excerpts of this research papers is into my next few slides, which would be like takeaway messages for you all to just a ready-made solution here. Although it will not be a substitution to reading the literature and going through the research papers, because here, because of the time limit, I may have restricted to some things, and therefore I suggest that when you have time, do go through literature and do read about these things, because this is one of the important area where you will have to master yourself if you are practicing sports medicine for athletes, for elite athletes, I would say. But yes, for even novice ones, you should know all these things, because challenges at different levels of participation are different. I believe, because I was working in the elite domain, and now I have started working on I'm seeing more grassroots people. Now I see that the challenges are much bigger, because the understanding is quite less, and the unsafe practices are more at lower level. And that's again giving me I mean, not it's a big challenge here, and I'm still figuring out how best I can guide these people. So what are the prevalent weight reduction practices that are available as of today? I'll divide broadly in three parts. That is restriction on energy intake, and the examples would be dieting or fasting. Restriction on total fluid intake. This will be restriction of fluid, that is mainly water, and increasing the sweat response, which can be included using the sweatsuit, the FBT, popularly known, apparel for losing weight amongst these combat athletes, and the other means that are like laxatives, diet pills, diuretics, enema, and bulimia. Out of these, we have some unsafe ones, which laxative, diet pills, and diuretics and all, they all come into the WADA prohibited list, and therefore should not be encouraged to any athlete. Obviously, these things do cause some weight loss, but their health hazards are too much. We cannot have a risk versus benefit ratio in the favor of these particular things, and therefore one should discourage these things. Obviously, we'll be talking about all these things. So acute weight loss methods, if I want to classify, and this is obtained from the research papers that we have, and obviously one of the standard document for this thing is the guidelines issued from the Australian Institute of Sports, AIS, and which are the basis for most of the textbooks and the research articles which are there. This is I forgot to mention here, it was obtained from the one of the paper from Professor Ron Magwan, and the different methods that are laxative or bowel preparations, food restriction, and low residue diet. We're comparing with the advantages and disadvantages, and some of the advantages that I can say is loss of 1 to 2% of body mass within less than 1 day. You can use laxative or bowel preparations, or even the food restriction method as well. However, the disadvantages are greater in these such cases, because they might be associated with decrease in exercise capacity, because of the loss of body water. Again, the signs of dehydration might set in, and electrolyte imbalances might be there. Obviously, one important thing about the food restriction would be hunger, and when the hunger pangs come, it is difficult to control, even if you have a great willpower, and your entire energy is wasted or seeped out before you actually go for a combat fight. So that's why these practices, I feel, should not be the ones you have to lose the weight step by step manner. I have prepared one slide separately where I feel that what worked for me as a team doctor and what worked for us as a strategy, which is also already proven. It can be one of the blueprint if you want to implement it in your life. There are other methods like glycogen depletion, one of the good method if used properly with scientific planning. Here, the more important is how many days prior you're starting this thing, because it takes time for an athlete to adapt to these method. And here you're just loading the glycogen and then depleting it with the training and with the timing, which is quite crucial just before the tournament. The advantage is you can achieve easily the 2 to 4% of body mass loss within 3 to 7 days, that is 1 week prior to the competition, and it will not have a significant effect on the strength and power in the briefer periods that are there in the competition zone. So that's why it can be safely used if done the proper planning. The disadvantages are it's associated with impaired performance of exercise, which is basically dependent on the anaerobic glycolysis, and therefore the one of the biggest problem with this is aggressive carbohydrate intake is required to reverse these things. And if the weighing is on the same day, then sometimes it becomes difficult to achieve the depleted glycogen, which was done eventually over a period of 7 days. And that's why one of the challenging method. The other methods which are commonly used, and I think most of the 70 to 80% of the people would be using this kind of method, is manipulating the body water content or the body volume of the water in the body. And I'll so there are 5 parts in which I have divided this thing, and this is again on obtained from the AI's guidelines. Moderate hypohydration, which means more than 4% of body mass loss. Mild hypohydration, which means less than 3 to 4% of body mass loss. Fluid restriction, which accounts to loss of 1 to 2% of body mass in 1 day. Active sweating, which is induced by the exercise. And passive sweating, which is heat induced, sauna induced, hot bath, heated rooms, and etc. So these are different ways in which water can be lost, or water can be manipulated in the various compartments of the body, and we have to look for their advantages and disadvantages of each of these methods. Obviously, fluid restriction to a smaller level, that is less than 1% of body mass manipulation, is something which can be tried, which will not have a bigger disadvantages apart from thirst and less physiological disturbances would be there. Inducing the active sweating and passive sweating using the sauna and hot bath will have its own course of action based on the dose and amount of for which it is exposed. Obviously, there are risks for dehydration, which can be set up. Electrolyte imbalances can occur, and most important, the literature available today do not have a significant support that sauna and heat induced rooms do cause a significant amount of water loss, significant amount of weight loss. Though they are known to cause water loss, and they have the evidence for water loss, but weight loss is something which is controversial because the muscles lose their water content, become more inelastic, which is not the requisite in the tournament, what we are going to fight, because that will increase the chances of injury, and therefore would be used with caution. So the biggest disadvantage of all this water manipulation technique is the risk of dehydration, which is a commonly observed thing. Even mild dehydration can impair cognitive function, reaction time, and decision making. I've marked it in red because for any combat sport, the most important thing is your cognitive ability to make a decision whether you want to go for an attack or a defense. If this judgment ability is altered by any means, then your scoring thing will be affected to a greater level. However, people do not understand this important fact, and therefore we are seeing a lot of problems with the athletes, especially the Indian athletes who are using weight loss techniques by manipulating the water, and some of them might have some cognitive function impairment during the day of bout, and they even don't realize. That's a sad part that we see. Some of them even sees slowness or sluggishness in their reaction time and decision making abilities, and that is one of the reason for not performing up to the mark or to the level which they had trained, and that can have a positive impact on the outcome, which may not be in your favor or in the favor of the athlete. That's why such things have to be explained, educated to the athlete, that decision making and reaction time and cognitive function are quite a bit linked to the your overall hydration status as well. If you have a mild dehydration, these things can be altered, and the overall outcome will not be in favor. Obviously, dehydration can also lead to fatigue, decreased muscle strength, and reduced muscle output. These are the accessory things which can happen, not on the immediate things, but a kind of a delayed response. The electrolyte imbalances can also occur, which are risks during the rapid weight loss, which is targeted. When I say rapid weight loss, it means that around more than 4 to 5% of the body weight loss, and more for the 4 to 5% of the body weight. And in such cases, you have to keep an eye on the hydration status, the electrolyte balance, and uh, the muscle cramps which can come up, the cardiac complications that can arise because of the electrolyte imbalances, that can be sometimes life threatening. You know, in addition to this dehydration, calorie restriction can also lead to muscle loss, further diminishing the strength and performances. So now we were seeing that there was a calorie restriction, water manipulation, and electrolyte imbalances. The cumulative effect of it can have a diminishing effect on the strength and performance, which obviously we are not supposed to go like it. So that's why if we want to have good strength and good performance abilities on the day of bout, then we need to pay attention to these things. Cramps, one of the most important indicator where you can see that the dehydration is setting up, and you need to correct the fluid balance immediately. Also restore the electrolyte balance. Obviously, we now know that cramps are not only linked to the electrolyte imbalance, it is also linked to the neuromuscular coordination and the neuromuscular impulses. So the theories are different, but obviously one important theory still remains whole good today, that is regarding the electrolyte imbalance causing muscle cramps. When we have to go for a long-term weight management strategy for a combat sport, this is something which has to be planned well in advance, which will ensure long-term success, which will ensure success because it can be proven, it can be repeated number of times, and the athlete is conditioned for doing that thing. If the athlete is subjected to crash dieting and extreme weight cutting, then that can be detrimental to his progress, because number one, he may be trying it only for the first time or maybe second time, and the effects cannot be quantified because they do not have any proven track record. And in that case, you require a long-term planning. I'm coming back to the basic knowledge again for the second time here, that we should not be skipping on calories. You should educate the athlete that dieting will not ensure proper weight loss. You have to eat and lose at the same time. So maintain the energy intake during the weight loss. The only principle that you should remember is, when you are targeting a weight loss, your intake should be less than the expenditure, but it should not be that you're restricting your intake and going on excess expenditure. So there are two different scenarios. One, you can restrict your intake and increase your energy expenditure. Other, you can restrict your intake but ensure that some intake is there, and at the same time, proportionate to that, the energy expenditure might be increased to a certain level within the limits of your physiological thing, planned well in advance. And if this done properly, then actually you can achieve weight loss based on the scientific practices. How, we're just going to see in next few slides, but before that, let me cover the basics. The next important thing is importance of protein during this weight loss, because you know that protein is crucial factor for muscle repair and wear and tear, which can happen during the acute weight loss strategies adopted within the day, within 1 day or 1 week prior to the competition. And therefore, even though you have a good muscle mass on your body muscle composition, the actual muscle which is available on for the action on that day of bout, the quality of that may be affected, because there might be the protein intake is not regular, or maybe it is not regulated in a fashion that has to be there. You have to aim for daily protein intake of 1.8 to 2.7 grams per kilograms of the body mass, and this is a range which is defined for a certain set of population. I repeat, this should not be the only takeaway message from here. For individual weight categories and different populations, there is a chart which is available, and you should be referring to that particular thing. Obviously, your local factors and diet preferences will also have an impact based on the NPP value of the proteins which is available. Obviously, those will be dealt better with the nutritionist, and even you can also go on with the recommendations looking at the charts available. Include lean protein sources like chicken, fish, or lentils in your diet, which will be a good source of protein when you are targeting the weight loss strategies. And this important slide is not just for the athletes who are aiming for weight loss. It is also for the for your daily practice. When you are suggesting somebody to lose weight, even a person who has sedentary life, the importance of protein is important for him also. You have to explain him the same thing. So these are some of the basics which remain same throughout. You have to manage the carbohydrates smartly and the glycogen depletion strategies smartly. When I say smartly, it means the amount of carbohydrate intake should be reduced so that the stored glycogen can be reduced, and body's energy source, which is important predominantly from the glycogen, it can be regulated. Obviously, this will require planning. I am coming to that, how it will be there. Potential benefit of supplement. So the question comes to me, and it is often coming to you as well. What supplement would be required when you are targeting a weight loss? So one thing is, if you have good dietary choice of protein and good dietary intake of protein, then obviously you don't need protein. But if your dietary protein is less, obviously you should be supplementing it with protein. And it depends on the person's requirement, basically, how much weight loss or weight however loss he is trying to target, and what is the amount of duration in that, and obviously his previous response to a particular protein, because we have seen practically that all proteins do not give the same results. There are significant differences in different types of proteins available, formulations available in the market, and the athletes respond to them differently. Some of them may have some GI effects to the athlete, some of them do not have that. Actually, some of them have taste problems with the athlete, and therefore it is individual customization required. The potential benefit of branch chain amino acid is something which is something you can consider as the support muscle protein synthesis. Therefore, there are certain researches which vote in favor of providing branch chain amino acids when you're targeting weight loss. obviously you have to have your own set of prescription for weight loss, and this is just one factor which can be considered. Most of the problems, most of the people might have gastrointestinal issues after weighing because of the sudden loss in weight, and therefore in such cases the rapid food intake after weighing can lead to this gastrointestinal distress. So the best strategy would be you have to start with small and easily digestible meals, preferably a semi-solid ones to start with, where there is a water intake which is being ensured, and there is a semi-solid fluid so that it is easily digestible. Simple carbs instead of complex carbohydrates, and that's what it will try to avoid the GI upset issues. Gradually intake the food intake as you are tolerating throughout the day until you are going for the bout. Just before an hour before the bout, you have to stop taking solid foods, and obviously then the water intake and all has to be calculated and taken accordingly. So the most important thing, because each athlete behaves differently, the strategies for weight loss have to be tailored for that particular athlete in order to achieve peak performance for that particular athlete. So it cannot be like one shoe size fits all. Therefore the strategies might be different and the manipulation methods can be different, and we have to figure out before in the training process rather than doing directly on the competition day. Obviously you have to consider body composition goals, training intensity and dehydration tolerances in these plans, and the past cutting experiences which can be included for development of such plan. Staying on the track for monitoring the hydration and electrolyte balance. Obviously regular monitoring is required for the hydration status during the entire process of weight loss. Urine specific gravity testing can be a diagnostic tool to assess the hydration level. Obviously this is one of the lab tests, but what you can do is the color of urine is one of the crude way of looking at the hydration status, and based on that you can just teach the athlete how to monitor his intake. Electrolyte balances should also be monitored, especially when there is a severe weight loss strategy being practiced, and if you see the signs of electrolyte imbalance, then early intervention is needed in order not to subject the athlete for the for the thing. I'm so sorry, I think we are nearing our time limit, and that's why I would like to wind up the things, going to the slides, scrolling through the slides. So time is important for weight cutting strategies, and there are two different scenarios which have to be seen. That is weight loss within less than 2 hours before the competition. You have to limit the dehydration to maximum 3% of body loss, and weighing on the day of competition, on the day before the competition starts, you have to consider slightly greater dehydration, that is up to 4% of body mass with close monitoring can be practiced. These are some of the excerpts of the AIS guidelines, and I think you can just go back and refer to these things. One of the important slide that I wanted to discuss is one that worked for me during my practice as a team doctor for boxing team, is this particular strategy where we planned almost 5 weeks before the competition for setting up the weight, the target weight. So that was the base of pyramid, start 5 weeks before the competition, and you have to move towards the goal, that is on the day of competition. Gradual weight loss and fat loss would be ensured using the dietary strategies as well as subsequent body composition monitoring. We used to do body composition monitoring because we had BCA analyzer with us in the team itself, and therefore it was done twice in the week just to keep a track of it. 1 week prior to the competition, the maximum weight we could ask the athlete to lose was 3% of the body mass, although the range is 3 to 5%, but we restricted ourselves to the minimum, that is 3%. And before 20 hours we just allowed the athlete to have a loss of 2% of the body mass. So yes, if in 50 kg of boxer wants to maintain his weight under 50 kg, obviously he should not be allowed to lose more than 1 kg, that is 2% of the body mass. If he is supposed to lose more than 1 kg, obviously we will be pressurizing this boxer to start a bit earlier, 1 week prior, or maybe 2 weeks prior, to just go on with the to just have a maintenance weight until the competition arises, and on the day of weighing you do not have any problem. Only 300-400 grams, some manipulation is required, and that is something which is tolerable even by a small fluid restriction method as well. So that this strategy really worked for me, gave a good results, and we didn't see problems with the athlete. Obviously I cannot comment for the entire boxing team and boxing section, because I was working with mostly women athletes, and sometimes some of the men athletes as well. But what I saw was a difference. We implemented this strategy for the women team especially, and that worked for us. For the men, it was quite difficult because their targets were too unrealistic sometimes. I did my best to explain them, but we have our challenges. This is not a platform where we can discuss that. But anyway, these are practical challenges which every one of us will be facing. After weighing, there are three important things: consideration, rehydration, glycogen restoration, and pre-competition nutrition. The guideline which is available today for rehydration is rapid rehydration is essential after weighing. The aim has to be around 125% to 150% of the total lost fluid, total weight loss, or total fluid loss during that entire process. So let's say if 1 kg of body weight was lost, then you have to target for around 1.5 kg of 1.5 liters of water to be replenished post weighing until you go for a bout, so that you can actually remain hydrated and you have a optimal performance on that. So there are two important strategies, two important step approaches. Large initial drink should be 600 to 900 ml of an electrolyte containing beverage, and which should have a flavor which is lighter in note. A strong flavor may cause aversion, vomitish feeling, and it can hamper the overall hydration process. The remaining volume should be given in sips at regular intervals, and the athlete has to keep sipping. So next part is replenishing the electrolytes. Water obviously was one rehydration fluid, but sodium replacement is again quite crucial. So it's a critical electrolyte which is lost during the weight cutting process. The target replenishment is around 1150 milligrams of sodium per liter of fluid. And the best strategies that can be done is choosing either a sodium rich foods along with the fluids, or using an ORS solution, or commercially available electrolyte solutions which contain sodium as part of it, and you can use it for replenishment. Obviously the important source, that is carbohydrate intake, has to
Sorry,
be
Amol,
ensured.
can you wind up quickly?
I'm
Sorry.
just finishing up. It's just last two things. Just scrolling through that. Important takeaway message on that: there is carbohydrate intake around 5 gram per kg and up to 12 gram per kg body mass when we are maximizing the refilling and weight gain. Just scrolling to the sides because of the time limit. I'm really sorry on that. Practice. You have to familiarize your food. You have to include these strategies in your daily practice, so that you can see the effect of it and then modulate it based on your choices. These are some of the charts which are available from the research papers and the examples that are there. Unfortunately, due to time restriction, I will not be. Yes, the last thing, that is, it's a champion's choice which strategy to be used and when to be used. Obviously your plans have to be chalked out well in advance. You have to prioritize a low fiber diet and moderate carbohydrate reduction for initial weight loss, so that you do not overload with your water or overload with your thing, because the fiber is less and it will help you to lose weight rapidly. Limit dehydration to maximum of 5% of body mass. Rapid rehydration post weighing process, and the experimentation has to be continuous to refine your pre-competition nutrition plan for optimal utilization. Combat sport success requires strategic weight cutting practices that has to prioritize the athlete health and safety. With that note, I think I end my presentation and talk here. We'll be happy to take away the questions, if any. Thank you so much for the opportunity.
Thank you, Amol. Thank you. It was such a wonderful talk in detail about combat sports, because I think this area has not been pursued much. So I would like to thank Dr. Amol for giving such a detail. We'll be taking the questions at the end of the session, so I'm asking Dr. Amol to please stay. Dr. Kenjom is our next speaker. I don't think we have, there is a lot to speak about Dr. Kenjom, because if sports medicine is, synonymous, it is Dr. Kenjom, because he's been in this field for way long than all of us together. He is currently the JCMO and the commander for sports medicine and trauma specialist for the CRPF. If I go into his team physician and tournament, there is a huge list, and I'll try to make it brief. Let's start with he was the medical and doping control officer and was the main lead DCO and manager for the ICC Senior Men's OD Cricket World Cup, which occurred recently. There was he is the Asian Junior and Youth Weightlifting Championship. He was the official in charge on behalf of the WFI. He's also worked as the team physician during COVID-19 21 with the senior national women's boxing team. He works with grassroots, semi-elite, elite athletes, amateur athletes, you name it, he's been there. There is nobody as important as Dr. Kenjom in sports medicine, and who has contributed so much. So definitely his topic is also something which is wonderful, which is something which is very interesting for many people. Thankfully, he's the best person to speak on it. It's overtraining versus overreaching training principles. I'll be share sliding right now. Sir, you can hear me?
Yeah, I managed to get in.
Okay,
And
sir.
thank you, Dr. Amol, for taking a little bit long because I was not able to log in. So me and Siddharth, I missed the last 15 minutes of your talk, 15-20 minutes. So I'm going to maybe have a session with you separately. So
you
can
see
you
the
let
slides?
me share, because to move forward, it's easier for me to do it. If I can't, if you share, then I'll have to keep on saying next, right?
Let me see, sir, whether I can do that.
You can allow me slide share. Because then I may not be able to move the slides forward with you sharing. Then I have to keep on asking you to say next,
I know, sir.
Can you just allow me slide share and just take this out?
Okay, sir, let me see. So can you just try to share, sir, now?
Yeah, I have this share. WebEx would like to record the system. Okay. Oh God. Just hold on a second.
Yes.
If I had to uninstall and reinstall, then I was able to get in. Okay, let's see. Am I still in the meeting?
Yes, sir. Yes, sir. You're still, sir.
Okay. Open system preferences. Okay, so what does it do? Doesn't it allow me to share?
So there's a down button in which you can press share, sir.
No, I've done that, but it's taking me back to my home page.
Yes, sir. If you keep your
Yeah, just a
PPT
minute.
open, sir.
Okay, let me do that. I'll just open the PPT first.
Yes, sir.
Is it coming?
So
No.
now just press share, sir. After you open the PPT, now press share, sir. It'll go to the PPT page.
Yeah, I know, but it's asking me for open system preferences.
Okay,
so
sir. Sir, I'll do the sharing, sir. You can speak, sir. It's okay, sir.
Yeah. But unfortunately, I don't want this next, but it's okay.
No, sir.
Then
I'll try to this thing, sir.
Just give me a second. What does it do?
So you can see the slide, sir.
Just a second. Yeah, I can see the slide, but okay. Let me just try from my side. Just give me 1 second more.
Yes, sir.
Because it'll be easier that way, Otherwise,
I
we'll end up struggling with the presentation just a little bit. Documents on desktop, maybe. Yes. Why is it not allowing me? Okay. Okay, I'm so sorry. I think we'll have to go your way.
Okay, sir.
It's I think this because I had to uninstall and reinstall. The probably there are a lot of permissions this iPad and Apple has to do.
No, sir. I understand, sir.
We already wasted a lot of people's time. So can we begin then?
Yes, the slide is on, sir. You can see the slide, sir.
Yeah. I just wish I could move ahead on my own through the slide, right?
No, sir.
So you'll have to help me. Yeah, just come to the next slide.
Yes, sir.
Okay, can we just go back again? Fine. So to the ISSEM team and all my colleagues and my seniors, thank you, Dr. Siddharth, for helping me out with. This is one of those rare incidences where he had his technical issues. I hope I'm audible and visible both now.
Yes, sir. Yes, sir. You are.
So thank you for saying, speaking a lot of kind words for me. But I think we have another stalwart sitting here, Dr. Kiran, maybe who's got more experience on the field than me, more mileage, you can say. And yes, I have been able to, or having the privilege, being in the uniform services, also additionally being based in Delhi, able to work with a lot of national, international teams and all that. So I always like to speak more on ground. So it's very difficult to follow up with speakers like Colonel Anup and Amol and before this Deepak and Chetan, but sometimes it's positive, it's a negative. The positive aspects I'm going to take a few days. A lot of things that I was planning to talk on has already been spoken. You see, they spoke about overload. They spoke about acute and chronic workload ratio. Recovery, again, is such an important part to prevent overtraining or even have super compensation on overreaching. So recovery is very important. And he's already spoken about, Amol, Dr. Amol has spoken about, hydration and all that. So Deepak spoke about jet lag and a lot of other things. So I think a lot of things would be easy. So I will be speaking on overreaching and overtraining, a little bit on the training principles too. But I feel, as sports physicians, what happens is we all know that when you look at sports medicine, it's very much synonym with injuries. So we all go on injuries, we all go on injury strip. Everybody's on for injuries. Just to let you know that sports medicine and trauma is not sports trauma. For me, the trauma is more of an ATLS. I'm an ATLS guy, advanced trauma and life support for doctors. So that's why the trauma is there. So it's not sports trauma in the designation. Okay, so what I would always like to speak on is, it's a very important topic, and especially the physician aspects, because we are sports medicine physicians, and also for people who are listening to us who are not sports physicians, we have to understand that uh, we seem to a lot, look at social media and everywhere. It's all about rehab and injuries, but there's a huge part of medicine which was already spoken. And I'm grateful to ISSEM for taking this topic up, where physiology and medicine is paramount to reaching peak performance, especially at the very, very elite level. So just starting on that, in the morning, Dr. Barun also spoke about overreaching, overtraining, overloading, supercompensation. So I'll just try and explain, to understand the differences between the three. Can we go to the next slide? Okay. So overloading, we know, is a period of increased training demand followed by rest to achieve improvements in performance. So when we say rest, I would also say where Colonel Anup mentioned was the recovery part of it. Can result in short-term fatigue and muscle soreness, but ultimately can improve performance with the correct recovery. When we talked about sleep and hydration and nutrition, has been shown to be beneficial in athletes not currently experiencing overreaching or overtraining symptoms. So this is overload in short, simple language. Next, please. Yeah. So we come to overreaching, where the negative progression of overload training, a period of increased training demand without adequate recovery time. It may result in a state of heavy fatigue, muscle soreness, short-term decrease in athletic performance. Typically resolves in a few days to weeks, but if left unchecked, this may then lead to overtraining. So overreaching is something that we can manage, but we have to try and not get our athletes to go to overtraining. And overtraining, in short, is negative progression of overreaching. It's a prolonged increase in training demand without adequate recovery time. Results in decline in performance, chronic muscle joint pain, depression, and personality changes. Symptoms of overtraining can last for several months and may ruin an athlete's career. And I know a lot of promising young athletes, especially at the semi-elite level, junior, sub-junior level, when they're just coming up. And just because the training load and the recovery was not managed properly, they've just disappeared. We've lost them. Next, please. Press one more. Can you? Yeah. So then even Dr. Barun spoke about supercompensation in the morning, and this is where the game is varying. I will come to the definitions further in the future slide, in the coming slides. But just in short, just to understand, varying each workout's intensity by changing the speed, resistance, and duration within the week, and mixing in lighter recuperation, which we can also say recovery, allows the body to recover in between training days to maintain a positive supercompensation. Next, please. So why are we talking about overtraining syndrome? If you look, overreaching, overload, overtraining, because performance. Ultimately, we all in sports medicine, you know, that's what I say. It's different from what we work in a hospital. When we work in a normal hospital setting, we save a patient's life, we manage the patient's limb, we treat them. That's it. But with sports, it doesn't matter how good your treatment is. It doesn't matter how good your science is if your athlete is not performing. So we are indirectly judged by our athlete's performance. That's a pro and con too. And that's the reason why everybody is jumping in the sports medicine and sciences bandwagon, because you get a lot of recognition for performers. So now that is why it's so important. So if you don't perform, your athletes don't perform, it's almost as if we haven't done our job, you know, well. So what are the performance indicators here when you go into overtraining syndrome? Early onset of fatigue, decreased aerobic capacity, especially VO2 max, poor physical performance, poor plyometrics, and their inability to complete workouts. You know, in Forge, the coach will come to us, or even now in India, not India, they say this guy is a makra. You know, a defaulter, he's a makra, he doesn't want to train, he's complaining, he's this thing, but he was working very hard, now he's not working, you know, and they blame so many other things. But sometimes we don't understand, but maybe it is an OTS. His or her inability to complete workouts, delayed recovery. So this all leads to staleness, stagnation, and post performance in training and competition. Then, of course, like I said, then we don't win medals. And if we don't win medals, it means we're not able to achieve what we have set out to achieve. Overreaching again, it's now I'll just talk a little bit more in detail. Overreaching again, we say synonyms used in literature around overreaching include staleness, burnout, failure to adaptation, under recovery. Not proper recovery means training stress syndrome, unexplained and underperforming syndrome, muscle failure syndrome, and excessive exercise. Next, please. Overreaching is a state of excess volume. Now is the scientific definition. For us doctors, excessive volume or intensity of exercise, heavy loads. The symptoms of overreaching are generally feeling unwell, disrupted sleep, mood fluctuations. It does not have any significant impact initially on the athletic performance. When training loads reached an athlete's individual tipping point, he or she can be considered overreached. With early recognition and allowing the body to regenerate with appropriate rest and recovery, which our previous 2-3 speakers have spoken on, you can understand. And their absence of more stress, performance can be increased through support compensation despite overreaching, with the athlete suffering from certain illnesses and all. I don't know, can the slide go up a little bit? Can we go back? So there was one line that I wanted to mention on it. Just a second. Why is it coming like this? Okay. All right. With the athlete suffering only a temporary performance. I think it's in the next slide. Okay. Can we go next? Yeah. So then we come to the overtraining syndrome. Is defined as an accumulation of stress due to training and additional life stresses that results in long-term performance decrement that may or may not be accompanied by psychological and physiological signs and symptoms. It is the maladaptation of physiological symptoms to the load placed to see adaptation in pursuit of achieving higher performance. Overtraining results from an increase in training and or non-training stress and poor recovery, leading to a long-term decrement in performance capacity with or without related physiological and psychological signs of maladaptation, in which restoration of performance can take up to several weeks or several months, or like I mentioned, sometimes the athlete no longer comes at that peak level, you know, whether it's any sport, it's tennis or football, and then coaches keep complaining, he's not, you know, he's hit the wall. So can we change and go to the next slide? So again, here, when we talk about training, obviously it's all about the load. So when we talk about load, when you do just a normal load or you undertrain, you are not going to go into supercompensation. You are not going to, I'll come to the supercompensation part later, a couple of slides. So we have to train and we have to learn how to load. So that is why it's very important to have everybody working together, because you and I as doctors or physios don't give the load. The only load that we give is only when they're injured. For an active athlete, unless you are a full-time doctor working with the team and with an elite athlete, it doesn't happen at the lower level also. So I just brought that into mind, because if you're working at elite level, yes, because they understand sports science. At a lower level, the coaches are going to tell you, I've been coaching for 24 years. I'm an Arjuna awardee. I'm a Dronacharya award. Don't teach me what to do. So it's very important to educate our especially the athletes and coaches for this. So overload occurs because we in India we have this concept of ragda, hard work, hard work, hard work and determination, hard work and determination. That seems to be just pushed into art. We're not talking about smart work. So overload occurs when the balance between external load and internal load is altered, so that the body's adaptive capacity is inadequate, resulting in manifestations of altered performance and injury or illness. So training load can be internal or external. Next, please. So training load again is the work completed by athlete during training and competition. We are having a lot of issues. Okay, so yeah, thank you, Siddharth. Our individual internal load are individual physical, physiological, and psychosocial characteristics that respond to external load. So identical external loads may elicit considerable different internal loads in two athletes with different internal characteristics. Like, they can be different for every athlete. Every sport, it is not the same. So we have to understand that also. It's also the body composition. What would be different? The internal load for the goalkeeper of a hockey team may be different from a forward, may be different from a drag flicker, from a footballer, from a midfielder. It can be different from the defense, or it can be different from the winger. So then the other measurements that we do is we go through the heart rate and the rate of perceived exertion, which I'll explain in the coming slides. Next, please. So here we talk about supercompensation. Supercompensation refers to the post-training period during which trained parameter has a higher performance capacity than it did prior to the training period. Supercompensation is the adaptive response of our bodies to a training program. In other words, by training hard and getting your work to recovery balance right. See, here sometimes that's what it's more than the work, it's also always recovery. We can achieve better results to sports training. Each individual will have their own optimum level of exercise and recovery to increase their base fitness level over time. So once we, go slightly higher in super elite level, we will need to tailor make. So that is what our first speaker did speak of, that we have the athlete monitoring system too. So you monitor each athlete and then you load them accordingly. We will have the baseline warm up, baseline cool down, baseline training, but after that, if you want to have the athlete to super compensate, or you want to overload it correctly, then you have to tailor make it. Next, please. So just one more click here. So this is already there. Next slide. I'd already explained the first slide. Next. So here, when we talk about I think I've already explained. So here, as you can see in the slide, that you have the base level, then you have before training, and then you have a training recovery in the correct manner, then you have a super compensation. And then, of course, you give the correct recovery and correct time, and then you keep on loading this and you keep on super compensating, and you will slowly improve either your timing, your performance, or your power, or your speed, or your agility. Next, please. So we just have 4 phases. Yeah. Okay. We just have 4 phases, which Yakovlev classified. So we have phase 1, where it lasts when in training. You have 1 to 2 hours following a workout. You have high stimulus results in fatigue. Then you have phase 2, where it lasts 1 to 2 days following a workout. Comprises physiological recovery and repair, which Colonel Anup very well, I think, when he spoke about recovery, when he talked about repair and the nutrition and the hydration and the rest, sleep, massage, everything. So possibly with delayed onset muscle soreness, rest of active recovery sessions plus good nutrition will promote a return to baseline fitness. Then you have phase 3, lasts 1 to 3 days following a workout. Supercompensation occurs as the body adapts and prepares itself for the next challenge. Any DOMs will fade and entry levels will increase, along with positive optimism. A new stimulus applied now will return the athlete to phase 1. Phase 4 then lasts 3 to 7 days following a workout with no further stimulus. Gains will gradually be lost, but we call it the effects of detraining. But once you increase your training, you will feel the benefits of supercompensation again. Next, please. So now again, we talked about why overtraining syndrome. So we've already mentioned this. Can we just come to the next slide? Next. Yeah. So the physical indicators of overtraining would be chronic muscle and joint pain, weight loss and loss of appetite, increased heart rate at rest, decreased sports performance, fatigue, prolonged recovery time, lack of enthusiasm, frequent illness, difficult completing usual routine, personality or mood changes, increased anger or irritability, sleep disturbances, difficulty in sleeping with or without being refreshed. So if you really look at these complaints, it's chronic muscle and joint pain. Yes, they are clinical complaints. Weight loss and loss of appetite. Sometimes the athletes don't come to you with that. They don't normally at the lower level. I'm not talking about elite level at national camps where they are being monitored by the sports science team. But at semi-elite or even an elite where they're not in the camps, and not all sports, where all the sports they're not doing this. So you have increased heart rate at rest, you have decreased sports performance. So they're not able to judge. They just say, oh, either the coach will say this guy is trying to escape training, or he finds the training very difficult, or will blame something on him, especially if it's somebody who's probably got some medal at the national level and then got a job, and they'll say, okay, he's lost his drive, he's lost his so that's why it's very important to recognize these physical indicators. Next, please. And the physiological indicators would be, like you say, higher resting heart rate. So if you work with any athlete, just teach them how to take the resting heart rate for 5 days. Teach them initially and after some time, and ask them to maintain a diary, and they can always check out their resting heart rate. Like changes in normal blood pressure. So when you do a screening in the initial part, like I said, with elite athletes, actually now it's easier in a lot of sports because they are following sports science. But at a lower level or semi-elite, we will need to push this. Delayed return to normal heart rate. So more of like recovery heart rate is poor. Then you have the elevated basal metabolic rates, the elevated body temperature, weight loss, excessive thirst, impeded respiration, subcostal aching, bowel disorders, psychological disorders, etc. Next. Next, please. Yeah. So it's the same thing which I explained, but it's more like I've just clubbed them into sympathetic and parasympathetic. We can go to the next slide, Sudan. It's almost the same. I've just wanted to define it into this. So we look at diagnosis of OTS. So we have the eating patterns, the POMS subscales. Then you have EROS simplified score, eating patterns, POMS subscale, basal hormones. You can go for cortisol levels and testosterone levels, the ratios. I'll not go into the detail of that. I think most of us in sports sciences know that. Then we have the EROS complete score, eating patterns, POMS. I think some of my speakers did speak about this also. Then you have basal hormones, hormonal response to ITT, body composition. Then you have your metabolites, your training rates, your double coupling, fitness tests. Then your neurotransmitters, immunological and redox parameters, EEG you can do, and you have your psychological questionnaires. Next, please. We had Women's Day, on 8th. So we always say, now we also see there's almost Olympics says 50% of athletes or competitions will be female, will be equal, equal to both the sexes. So this is the problem. I don't know how elite level, it's slightly different. The athletes are educated, they talk to you directly. A lot of times our athletes, sometimes intentionally, sometimes I don't know, but I've also noticed that even basic things like the menstrual cycle is not discussed. So whether it's a female or if and most of our coaches are male. So if it's a female coach also, I've seen, what is the problem? Why hasn't the athlete come for training? Sir, female problem. So they say female problem and they're not training for 5 days. They're not training for 6 days, 7 days, whatever. So number of times you kind of have to push them, especially because in India, I think, these issues are still there. So whenever you're working with female athletes or their coach, I think we need to address this, and that's the reason also when you look at all the research studies, because of the hormonal cycles and because of female, I think more studies are required for this, OTS in females. We cannot say when you do a study together, male and female would be the same. It would be different. So how to improve athletic amenorrhea in and overtraining? You decrease training intensity duration by 10%, attempt to increase body weight, supplement calcium intake, gain psychological support. So important. If amenorrhea is persisting after 3 months of modifying behavior, take medical advice. And definitely whenever there's an issue, they should have a screening of an OBGYN. Definitely. I ensure that I do this with all my athletes. I have the advantage of having a sports nutritionist as a female and a sports psychologist, again, who's a female. and sports. We also have sports female. So what I do is I make the guidelines and I let them handle that for me, even during the screening and all. And even then, I've also seen within female to female also, unless they really gain confidence on the physio, on the nutritionist or the psychologist, our athletes don't really talk about it. So when we don't talk about it, then how are we going to address it? So I think we need to educate the coaches, we need to educate our physios, our psychologists, our nutritionists to look at to this also. Next, please. Practical recommendations. Siddharth, I'll need your help to just shorten this. I don't know why the black spot is coming down on my laptop a little bit. Just a minute. I'll do is I'll alternatively open it here. But the others can't see it. That's another problem, right? Okay, so this pic was just put simply, I was photobombing the female team and just trying to tell them that if you do the right training, even your doctor can have better muscles than the players. So you rest for 6 to 12 weeks. When we look at female, it's almost the same for the males too, but this was something that I took out from research papers. Rest for 6 to 12 weeks, include very light training and rest period, consider cross training. So what happens is, even if they're having periods like they just don't train at all, and they don't even discuss. And number of times I found out that actually the athletes had gynecological issues. They had dysfunctional uterine bleeding, they had POCS, they had a lot of other issues, which, fibromyalgia and all that. So this definitely needs to be addressed. That's why I put it at least a couple of 2-3 slides on this. And then of course you consider cross training in the rest period. Like in the rest period, say supposing I have my swimmer. Now they don't even know that they have a menstrual cup that they can use if they have to train pre-competition, or that they can alter the period. So they can plan the periods, they can plan their menstrual cycle, and you consider alternative cross training for them during this period. It's not necessary that they need to go and just do weights or run. So we will need to educate them on this. And of course, undertake relaxation techniques. Relaxation techniques are through psychology, through yoga, and through things that they love to do. Maybe, somebody likes to go watch a movie, somebody likes to do shopping. So it's like that. Consult sports psychologists, counselors who specialize in rational emotive behavior, utilize imagery techniques and rest periods, speak to the athletes and educate them, the coaches, the trainers, etc. Next. Just go to the next one. So this is just for the athletes. Tips to avoid overtraining. Advice to athletes to avoid overtraining. Listen to your body. Monitor your training. Nutrition, sleep, and stress. Take recovery days. This can be both active and passive. Don't increase volume, extra mileage, and intensity speed at the same time. That's what most of the time they'll do. I'll see that number of times we know that when it comes to loading, you're going to have today they had a long day. And I remember sometimes they do screening tests. So they had a very heavy training yesterday evening. There was no recovery, and they're doing the yo-yo test today, or they're doing the basically screening tests. So I think these things are very important to ensure that you have. That's why it has to be a teamwork. If the strength and conditioning guy is not in the team, and sometimes he's not working there, he's in a center, and the athletes come and we find out that yesterday they had a very heavy plyometric schedule, and then today we're going to test them with a Cooper's test or on the treadmill. So that is very important. Next, please. So here again, we now just come to the basics of principles of sports training, which we all know. So this is one of my favorites. We have so many other principles, the FIT principle, the SET principle, but this is one of my thing which I teach even our trainers in soldier training. So proverbs, it's easier to remember also. So proverbs, so it's progression, so we know progressive overload, regularity, overload, variety. You need to change, you need to do different exercise, work different muscles. Recovery, already we had a brilliant talk. Balance of everything. Basically, when I say balance, it's not balance in proprioception, that's also included, but it's balance in nutrition, balance in training, balance in your social life, in your personal life. That's also very important. And of course, specificity. You need to then again be specific with your exercises too at the same time. So that's why now it's, I would say, sports science is so important. We have to have a very, very holistic approach when we're dealing with athletes. Thankfully, I think at elite levels, most of the sports in India now are coming. We are having the sports science team, but look at this is the team we need even to push through with one athlete also. So this slide basically means that along with the principles of sports training. So when we spoke about progressive overload, this is one of the slides that I loved long time back. I saw, I have always kept that when it was told, there was a Greek mythology where this Spartan, the Greeks were very famous for being physical and warriors and fit and Olympics. So his father gave him a calf, and then as he grew along with the calf, he was given this responsibility. So that's why you have to plan the strength and conditioning very well to just not only prevent injury, but also to prevent overtraining. Next, please. So then we talked about the set principle to specific adaptations to impose demands. So, like most of the people, they show a finished product. So here you can see that we have day 1, then day 90, then day 70 of workout. So you have specific adaptations to impose demand. And even in bodybuilding or when you're working out, not even just an athlete also, even when you're going for normal training, what are your goals? So I think you have to put your goals, and then of course you have your, you adapt accordingly and you train your athlete accordingly. Next. That slide which just popped up was more like, if you can see, we adapted as human beings, and so we started off, from being a monkey and an ape, and then see like now, because we need to sit, stand, walk. So this is how we are, over the years, this is how we have also adapted. Human beings have adapted. Darwinism. Next slide, please. So again, a little bit on the training response. We have increasing intensity, duration, and frequency of training. I've already, I think, discussed in words before this in the previous slides. So I'll just come to the overtraining part, where you see the physiological maladaptation, performance decrements, and overtraining. So we have a zone of enhanced performance in competition and training. So this is acute overload and overreaching. And of course, you got to push and recovery a lot. Next, please. This is the general adaptation gas, which is identified by Hansel. Our stress response, defense, then fatigues. So this is just the slide, a graph. I'll explain this in the next slide, please. So stages of adaptation we have. We have stage 1 where you have alarm, you encounter stressor, body reacts with fight or flight responses, adrenaline, cortisol are released, the body's resources are now mobilized. And then we have stage 2 is the resistance. The parasympathetic nervous system returns many physiological functions to normal levels while body focuses resources against the stressor. Blood glucose levels remains high, cortisol and adrenaline continues to circulate at elevated levels, but outward appearance of organism seems normal. So we have an increased heart rate, blood pressure, breathing, and body remains on high alert. Of course, then we look at exhaustion. If these stresses continue beyond the body's capacity, we will exhaust all our resources and become susceptible to disease and injury. Next, please. Again, this was just a simple explanation and adaptations to exercise. As you can see, if we have a non-functional extreme overreaching, intense training stress causes irreversible maladaptations and performance stagnation. Recovery requires weeks to months. And if we go into overtraining, this is what we want to avoid. We increase training stress again to overreaching will cause of resistant maladaptations and prolonged underperformance. Complete recovery may not sometimes occur too. Next slide, please. So is there a way out for OTS and OS to prevent? Can you just make one more click on that? So I know we have little shortage of time, so that's why I'll not go too much into details, but at least I'll try to summarize it up for you, like how we prevent. So we have to have training load management. Then we have to have a periodized plan. Again, it's very difficult today with commercialization and with number of tournaments and matches with money involved. So sometimes, ISL, for example, the first ISL, Dr. Deepak was also there, Dr. Chetan was there, they spoke about it, where the athletes just had injuries left, right, and center simply because of too much of overloading. They didn't have a plan. They were playing back-to-back matches, and the days they were supposed to rest, they were traveling on the flight, home and away matches. So I think now they have slightly bettered the plan, but I still think that it does require 2-3 matches in a week is too much load on the athlete. So then you monitor daily wellness. Regular assessments are required, which we already spoke about. Next, please. So I think load management was spoken up by our first speaker initially when he spoke about athlete monitoring too. So I think I'll just come to the next slide now. He also spoke about, next slide, please, acute on chronic load ratio. And yeah, just keep on that sweet spot because he already spoke about it. So this was already spoken for by our first two speakers. Next slide, please. Yeah. So again, he mentioned that we need to stay at 0.8, to 1.3 of the sweet spot to decrease just not the injury risk, but also overtraining at the same time. So this is also explained as just a gentle reminder that we have to find the sweet spot for the athlete and we have to know acute and chronic workload ratio. So let me tell you very honestly here, I'm not ashamed to say it. Uh, when we were doing PG, I didn't understand the concept too much. But because I'm an athlete myself, so I understand. So I knew like how to plan my training, how to plan my sweet spot. So one of the reasons probably I always remained injury free. Excepting in football, when I was playing in college, we have kick left, right, and center. That's a different thing. But normally talking about intrinsic injuries. So if we stay in the sweet spot, we are going to have positive overload or positive overreaching is what I would like to say. Next, please. Next, please. Periodization again, we all know. It has to be organized, systematic, long-term planning of training to optimize performance at a given point of time. But if you really look at it now, you have also seen some cricketers have withdrawn because of injuries, because I feel that the workload is too much. We spoke about cricket also in the morning, and he mentioned that you have the bowler. So you ask the coach what to plan, but if the bowler is doing well and taking tickets or taking wickets and restricting the athlete, you find out that the guy has bowled 30, 35 overs in a day, and then they come to you after a few days with hamstring injuries or back injuries. Same is with the footballer. In hockey, that is why the national level I've seen they do because of the rotation system, which is really good. But I'm just telling you because I also go as a tournament doctor. I also go as a team doctor. And I've seen number of times, even if the rules are there, people don't substitute. Oh, he's my best player. He has to start. I am not going to, he's going to be Ragdoll. So that's how we end up having injuries. So I think it's very important to plan athlete to athlete and team to team also, and to plan your tournaments. Next, please. So again, just a little small slide, which we all know: preparatory period, the competitive period, transition period. We have pre-competition, main competition, tapering off. Next slide, please. So here, just a small, I'll just explain this in short. You have prepare, like say training phases, you have aerobic, anaerobic training, plyometric training, weight training. So if you just look at the slide, you have a preparation and conditioning phase where you work a lot on aerobic, depending on the sport, of course. I'm not going to do aerobic plus with my weightlifters. So of course, then maybe we go anaerobic plus and aerobic plus. So plyometrics training here, weight training and technique at plus. But I would probably, in my personal experience, I would like to add one more plus on the technique in preparatory conditioning. But depending from sport to sport, you see, if you're looking at badminton and tennis, it's all about skill. So I cannot have just so much of weightlifting and so much of aerobic training. So I'll need to have my skill and technique training also. So we have preparation, condition, then we have a transition pre-competition. Of course, that we can go plus to the technique training. And of course, we also need to talk about tapering off here. So competition levels, you don't do aerobic training, anaerobic training. You have your weight training and of your technique training. Even the technique training should come down because then it's I would think more of tapering off. Like for example, when we talked about periodization of competition, there were times when you just had few competitions. You had your district, state, zone, uh, then a couple of very important competitions, then nationals, then international few competitions. Like look at the top athletes. I'll just look at tennis or badminton. If you're a top 10 player in the world or a top even 50 player, you're week to week to week to week you're playing. So you're playing, you're traveling. It's not even in one area. And then of course we talked about the jet lag. We talked about so many things, where the recovery is not happening. That is why you'll see that athletes just pop up suddenly and they're performing fantastic. And suddenly after 2-3 months, they take a dip. So that's why you see, like, we talk about tennis because it's my sport. Federer, Nadal, Djokovic, they started, planning their tournaments. Even sometimes it's because they have to defend the points. And one of the reasons in tennis is you have to defend your points. You play a tournament this year when you're a new guy, you win the points. If you win 1,000 points or 2,000 points or 500 points, if you don't play the next tournament, the same tournament, you will lose your points. You have to defend your points. So that is the reason why also the athletes, have to play so many tournaments. And of course, like our previous speaker also, I think Dr. Deepak did mention that you spend so much money. The club owner spends so much money. He wants his star player to play because the public is going to come, the TV is going to come to see the star player. So there are a lot of other issues that at a social level too that needs to be addressed. When we talk about periodization, we just can't look at just one angle of scientific training. Next, please. So I think that RPE scale also was already spoken of by our first speaker. I feel that you should use the RPE also and discuss with your athletes whenever you have a time. It's available on the net, your RPE, and you can design an RPE related to your athlete and your team, and you can tailor make it. Next, please. And again, with the RPE, I also feel that daily wellness is very important. The wellness, that daily feeling of being good, feeling happy. I cannot perform a fantastic tournament. It's good to see on movies and all, but if my grandmother is admitted in the ICU, if my body is not feeling good, I have not slept yesterday because I had a fight with my wife or with a husband or my children. So I think the social aspect also is very important. So that's where our sports psychologists need to come in a lot. So we have a daily wellness, like you have your mood, sleep quality, energy levels, muscle soreness, what you had, your food yesterday, today, stress. So, you can always ask them whether they're highly unavailable, irritable, snappiness, less interest in other activities, good mood, positive mood. So I think if we also take care of the daily wellness and we chart while we're also doing the monitoring for the athlete, this would also be very important. Next, please. Please go to the next slide. Just wanted to show in this slide that high training overload by itself does not cause injuries. It is also a lot to do with the recovery. So now I'll always say for the OTS, it's always prevention is better than cure in most of the disease everywhere we talk. So same as OTS can really be prevented. So periodization of training wherever possible is why I have written it. Tapering for competition, adjust training volume and intensity based on performance and mood, ensure adequate calories for training, ensure adequate hydration. This has all been spoken about. Ensure adequate carbohydrate ingestion. So nutrition, basically in recovery nutrition. Ensure adequate sleep, very, very important. Promoting mental toughness or resilience as a buffer. Rest periods of greater than 6 hours between exercise bouts. I'll mention here that one of the reasons why I'll see in tennis or badminton, especially young athletes, where they pay coaches, they pay for the courts. So when they are training, so I've seen that very good players, what they do is they have a morning session training, then they have to go to school, and evening session. So the guy finishes training, the guy or the girl finishes training at 12, 1, then they have a quick break, lunch, maybe take a nap for half an hour in the car. Okay. And then they're back to training at 3:34. So there is no gap. So that's the reason why I believe that's in India also. Sometimes we look at the old school, you have an early morning training, then you need to have that gap for recovery. You need to have recovery rest periods in between exercise bouts. That's very important. And of course, abstinence of training following infection, heat stroke or stress periods of high stress, etc. Like in India, we have this mard ko dard nahi hota hai. And whether you're sick or ill. Yeah, if you're sick and ill, like we said, even with females, if they are not well, you can taper the training, you can tailor the training, So, but you don't just keep on going. And of course, we avoid extreme environment conditions, which already my previous speaker had spoken about, extreme heat, extreme cold, which is in India. It's crazy. Like you go to Patiala, it's very hot in the camps, and then it's very cold in the winters. And of course, utilize profile and mood states for stress. So we need to, those who can afford, should afford, or if you cannot afford, at least guide the athletes to the sports psychologists. And I think amongst us, we can all work with, I have somebody with me, you must be also knowing. So if a poor athlete cannot even afford to pay, maybe pro bono, we can try to incorporate this. We educate the coaches. So I think sports psychology also needs to be put in, not only at the elite level, but even at the grassroots or semi-elite at least. So we don't lose these young athletes to overtraining. Next, please. So like I said, again, integrating specialists, the way a team plays as a whole team, it's all together. So I have 5 minutes more, 2 minutes, 3 minutes.
You have, yes, sir. You have
Okay.
2 minutes. You can take, sir. No problem.
So this is where it's more like a takeaway. So we look at SPART management. So summarize everything up. So until a definitive diagnostic tool, for OTS is present, easy to coaches and to physicians, we need to rely on performance decrements as verification that an OTS exists, overtraining. However, if sophisticated laboratory techniques are not available and they are expensive, the lab costs are expensive. If you're going to send an athlete for just the basic hormonal profile, lipid profile, thyroid profile, LFT, KFT, all those, it will cost in the market today anything from 12 to 15,000. So I mean, just imagine most of our athletes are not from very well-to-do families. So till then we develop some app, something is developed, we will need to look at the physical parameters, and decrement in performance. So how do we do that? So you maintain accurate records of performance during training and competition. So one way is also, I see that most of even the semi-elite athletes, we keep on shouting at them, we keep on telling them that maintain a diary. So they can maintain a small diary and write what did they train today, what did they do, how did they feel good. So you can have that to fall back on a weekly record. Be willing to adjust daily training intensity, volume, or allow a day of complete rest when performance declines or the athlete complains of excessive fatigue. Avoid excessive monotony of training. Again, the same, drills and the same training over and over again. So that's also needs to be taken care of. Always individualize the intensity of training. Encourage and regularly reinforce optimal nutrition, hydration status, and sleep, which we spoke about. Be aware that the multiple stresses such as sleep, loss of sleep disturbances, etc., jet lag, exposure to environmental stresses can be also a huge issue, whether it's an elite or semi-elite. Next, please. So resumption of training should be individualized. Again, communication with the athlete through an online training diary about the physical, mental, and emotional concern is important. I said online also, even through a small little diary. Include regular psychological questionnaires to evaluate these emotional and psychological state of the athlete. We have most of the questionnaires in English. Maybe we can, South can have separate one, a Bengali, a Punjabi. So maybe we can start working on that too with the questionnaires. Maintain confidentiality regarding each athlete's condition, physical, clinical, and mental. I think this is very important because, as usual, a lot of people tend to put on social media or discuss with other athletes or coaches or other coaches, so on their physical, clinical, mental, and injuries, etc. So we should refrain from doing that. Importance of regular health checks performed by multidisciplinary team like the physician, the nutrition psychologist, the gynecologist, the orthopedician, etc. And we all should always allow the athlete time to recover after illness and injury. Next. And in that, of course, that return to play, return to sports, not only in injuries, but also to illness also can be monitored. Note the occurrence of URTI and other infectious episodes. Why is the athlete getting repeatedly infection, repeated UTIs, repeated tonsillitis? These things also need to be looked into. Encourage to suspend training or reduce the training intensity when experiencing an infection. Always rule out an organic disease in case of performance decrement. It should always be looked at because we have many times found out that they have been having some problem or the other. I even had an athlete, I'll not name an athlete, a top level athlete, suddenly not performing, not doing well. And also when I was just doing a regular screening, I found out the hormonal was a little bit, not, I suspected that the athlete was doping. But when we went through a series of tests and all, we found out there was a tumor. So these things also we should take care of and not just focus only on injuries. And of course, unresolved viral infections are not routinely assessed in elite athletes. Again, like I said, any infection or anything we should look into these athletes properly for illnesses. Next. So this is my thank you slide. So I just put this one little trophy here with to show that if you plan your training properly, and being a doctor, busy working, I don't go to the ground and play. But whenever there's a competition, I get to know. Just simple example, I've not been playing. I go to start with kids. So I'm going to start with just shadow. I'm going to start with one. I always speak about this to the athletes based on my capacity. I ensure that I don't overtrain. And I stay, and you can see here that I have a decent muscle bulk, as good as any athlete. Okay, and I train with international athletes also. So if you take care of your periodization of your training, you plan your tournaments, you plan your game, and you have your goals correctly, I'm sure that we can all be champions. Next slide, please. So thank you again so much, ISSEM, for giving me the opportunity to speak to all of you. It's been a pretty long time. And I wish you all good luck in all your endeavors. And if you wish to contact me, this is for those people outside of ISSEM who are not able to reach me, my email and my phone number. And once again, I thank you because, normally ISSEM always sometimes ask you what you would like to speak on or my specialty. I think I do not even challenge Siddharth or when he just sent me. And so, in fact, I thought that when today Varun said he spoke that more about physical training. And actually, for me, physical training, if I knew, I had a lot of slides on physical training because I do a lot of prevention of training injuries in the forces. So it would have been easier. And so I went to OTS, I went to overreaching, although we seem to know about it, but it's good that I also ended up revising a little bit. And then I tried to, Dr. Siddharth and our ISSEM fraternity, because I also know that you're putting this out on YouTube and a lot of other non-medicos, non-sports physicians are there. So I didn't stick too much into the science aspects of it. I tried to generalize a little bit. So thank you so much.
Thank you, sir. Thank you. Thanks a lot, sir. I know at the last minute we started having difficulties.
Technical glitches, yes.
It's always because it was a wonderful talk. Just like you said, sir, this has been going into YouTube also, and definitely we have young speakers, young viewers, means young sports medicine doctors who have not exposed too much. They read the theory part, but when it comes to practical, it is a little bit difficult. So you've explained it wonderfully, because when I just completed my sports medicine, I used to wonder what is this overreaching. And then when I had my first overtraining athlete, only I learned it through the hard way that, okay, this is what it is and this is how you have to go about it.
I'll just like to put in a word here.
Yes, sir.
Dr. Ashok Ahuja sir taught me overtraining. I remember in one of a conference hall, we 6 PGs sat down, and then and Ahuja sir had only 3 slides and he spoke for 2 hours on 3 slides. I needed 40 slides. That's the difference with the Guruji.
Yes,
So,
sir.
we were lucky that we had sir to teach us.
I know, sir. So I've got a few questions. I'll just finish it off as quickly as possible. Anup sir, are you there, sir?
Yeah.
Sorry, sir. I think I muted you. Yeah. Yes, sir. I have one. Yes, sir. So one question which was asked was, so does recovery technique change based on sports? For example, long distance to short put, does like an aerobic and an anaerobic? So does it change in the recovery technique? What is being applied to the athlete? Does it change?
Yes. So recovery technique, I just spoke in one of my slides. Basically, recovery techniques have to be tailor-made. The first thing is the age of the athlete, the sex of the athlete, the weight category of the athlete, the sport of the athlete, and the type of training which the athlete has undertaken. So all this will determine the recovery technique which you will choose, plus what is available to you.
I'll just add, Colonel Anup, that's why I said we made my job very easy, because thank you, Colonel Anup, for such an excellent presentation. And I don't know if anyone heard the part age. So athlete to athlete, and also the level of the athlete. See, if the athlete is already at a top level into training, already physically fit, they just need to stay, at that level. So also the training and then the recovery also. So for them, the recovery would be more important.
Okay.
So, and then whatever techniques are there, like he also mentioned, I'll just revise that on the peak of the pyramid, he had shown that fads. So we all know fads. Suddenly you have everybody going for cupping and everybody going for, so stick to what, again, he says is available, and also what evidence-based medicine says a little bit.
So one more question to Anup sir. So what is your opinion on recovery supplements? Like super EPA, curcumin, citrulline, BCAA, what is your?
Yes. So I told you that nutrition is part of the big 3. So there is no question that nutrition is very important. You can take supplements because when you finish a competition and by the time you reach the hotel, it takes about 2 hours, sometimes 3 hours. And you've lost the 60-minute recovery window, which you have, which is the ideal for, maximum recovery. So yes, you must take supplements provided they are dope-free and they are certified dope-free. You can take supplements and try and avoid herbals, because we do not give herbals to sports persons. So supplements, yes, judicious use and dope-free supplements, and no herbals.
Thank you, Anup sir. I'll come to Amol, Dr. Amol. There's one question for you. Kiran sir, please.
Presentation. What would be?
Yes, sir.
It's not clear, sir.
For example, post football match is
Sir, as it was mentioned in the prescription and the presentation, cold water immersion or ice is a recovery technique with a good level of evidence. So yes, scientifically also it is recommended, anecdotally also it is recommended, and psychologically also for the placebo effect it is recommended.
Coming to Dr. Amol, this question was asked, does your plan based on weight cutting, does it change based on weight class? So there are different weight classes in boxing, in combat sports. Does your plan in weight cutting, does it change based on that, or is it total, how much weight they have to lose? Is it only on that? Dr. Amol, are you there? I can't hear you.
I think he was there just now.
Yeah. Suddenly his voice went off.
What was the question? If we can't reach him? Dr. Siddharth, I lost you there. Amol is back.
Yeah. Hello.
Amol, there was a question for you.
Yes, sir.
Siddharth, you're muted.
Can you hear me?
Yeah, better now.
Yeah. Dr. Amol.
I can't hear you.
I think some volume thing must have been clicked on yours. Volume has come down.
Just 1 second. I'll just close a few things.
Yes, better.
You can hear me now? Better?
Yeah, loud and clear.
Yeah. So based on weight class, so does your plan on weight cutting change on weight class, or is it on the amount of weight loss is required?
See, as per the guidelines, it is the amount of percentage of body mass lost. We have the guidelines, but from practical experience, what I observed in the little thing that I had experience with the national is the weight cutting strategies for water manipulation method work best with the lower weight categories, particularly less than 60 kg athletes. For higher weight categories, usually there is not a problem of weight loss per se, but if you do have, then a combination method might be required in that cases. Although the athletes who are above 70 69 kgs usually do not require those things. It's a problem with the lower weight categories, and it can be managed easily if they are taught and well educated in advance. The problem arises when you are focusing almost 2 kgs of loss or over 2 to 2.5 kgs of loss in less than 1 day. And here we had some experience with one of our top boxers who were not able to recover properly within the time between the weighing and the bout. So typically what happens is we assume that we will have 4 hours after weighing before the session starts, as per the rules as well. But sometimes this time can be minimized to 3 hours, and it is permissible as per the rules as well. Not less than 3 hours is allowed. So minimum time limit is 3 hours. I'm talking in relation to boxing per se, so to understand this topic. And here in some instances we had issues where the time was too less to rehydrate the person, as well as to give him a carbohydrate meal as well. Because if you try to give too much of carbohydrate load, and that's what I was saying, that glycogen depletion is a good method if it can be planned in a better way. But the problem is to reverse that thing post weighing. There is a huge amount of intake which has to be ensured, and it is proportional to the weight loss in the targeted weight loss done in last 24 hours. So that mismatch has to be balanced. Rest, things are quite simple.
Thank you, Amol. I'll now, the last question, I'll give it to Dr. Kenjom. This is from our member, Dr. Guru. Kenjom sir, you can hear me, sir?
Yeah. Ask Guru to just come over to my place and have a cup of coffee and I'll answer all his questions.
Anyway, he has asked, sir, what is your experience with the use of wearables for load monitoring in athletes? And in your opinion, which parameters should an athlete or coach focus to avoid OTS?
Okay. So experience with wearables is both when we were doing our PG, I think all of us got the experience there. Number one. Number two, when I was working with the national hockey team, yes, the GPS. The problem with these wearables is that we can't afford it. It's so expensive. If you really want to, it's the software, the GPS, the thing, it's so the top level, even I don't know if the ISL teams have it. BCCI has it for the national team. The Ranji team doesn't have it. So I don't know now. I think the most important again is like it depends on your specialty. If it's the coach or the athlete, then I think wearables nowadays with the watches. So all these smart watches will give you some idea about your heart rate, your resting heart rate. So the resting heart rate, the recovery heart rate, maybe that is something to work on. That would be important. And of course, your GPS also, you have the GPS system where you have the athlete monitoring system, which if you remember our first speaker spoke of, when he said you can have everything from how much he stopped, how much he did a cutting, how much he. So I think it all depends. If one question to Dr. Guru would be, what is your budget? And then, of course, if you're working with elite athletes, you need to combine the wearables with the with the physiology, with the biochemistry and the physiology, because then you will need to work on that together. So I think with the along with that, because then that gives you a little bit more evidence. Lactate, say for example, you may do all the variables in terms of heart rate and cutting, mileage done and everything. That's great for the top level athletes if you have budget of more than 1 crore for one team. Okay, so and beyond that, of course, then you got to do it. I mean, you got to have a holistic approach. We just don't trust the variables, but if you have the budget, definitely. If not, with low level athletes, what I do is everybody buys a smart watch. You don't have to go for an Apple Watch. You just go for the normal watches and all. Top level, even those who are playing nationals and all, now they've understood, they've started buying that Garmin and all that. So they have the information on the watch too. Because it's some of the top watches, Colonel Anup. Also, I was just about to say that. I was just about to say that he also, Colonel Anup also had spoken once on recovery and wearables and ergogenic aids. So I was going to hand over to him. So he takes on from here.
If you don't have the budget for a full suite of wearables, a simple poor man's cheat is just look for a wearable device which gives you heart rate variability. And heart rate variability will give you a lot of idea about what's going on with your athlete, including the stress, the psychological stress, and the load. So if you cannot afford a full suite, go for a device which gives you heart rate variability. That will give you a lot of parameters which you can monitor and tweak and adjust.
Okay, sir. I think our questions are done. I would like to thank all the speakers, Dr. Kenjam, Dr. Anup, and Dr. Amol, for giving their valuable time, on a Sunday to spend with us and give us such a wonderful talk. We'll be breaking for lunch now for half an hour. So at 2 o'clock sharp, we'll be back. We have some good topics and interesting topics, which is not usually spoken about. So we'll see you at 2 o'clock sharp. Please do join in our YouTube live as well as in our for members in our WebEx, and hopefully I'll see you till then. Thank you, everyone. Thank you.
Thank you.
Thank you. Bye-bye.
I'm going to stay. I won't log out. It's a great difficulty. I managed to come in. So